So this is the third annual practical pediatric neuroscience symposium that we've done. And the effort here is to provide a bit of community outreach in our effort to create a partnership with the physicians in Central Texas. And so today's program is, it's quite exciting, I think. There's neuroscience is very fast moving these days, lots of new developments. And so today we have topics ranging from immunology of the nervous system to practical issues of pediatric neuromuscular disease, head size and odd head shapes, tics and Tourette's. And as Dr. Keith said, several of these speakers are new to us and to the community, so this is a way of introducing. And then this afternoon we have a cluster of talks, all of which are related directly or indirectly to the broader topic of pediatric headache. So Dr. Pavitt kicks it off with a talk on pediatric headache, and then we've got input from our headache clinic psychologist, from one of our neuro-ophthalmologists on pseudotumor, and there's another one. Sorry. But anyway, everything at the end is kind of related to headaches. And so all of these are presented from the standpoint of primary care. So hopefully your time, you'll be left with some practical points of diagnosis and treatment that you can actually use on day-to-day. So without further ado, I'll kick off the first speaker. This is Dr. Manny Moodley. Manny joined us 2 years ago, three now, two and a half, from Cleveland Clinic, where he was the head of the pediatric neuroimmunology program there. And he's going to talk to you appropriately enough about demyelinating diseases of children. So, Dr. Moodley.
Good morning, everyone, and thank you for attending so early this morning. So my talk today is going to be on pediatric demyelinating diseases. I have no disclosures of relevance to this topic. And in terms of overview, over the past 10 to 15 years, there has been significant progress in understanding pediatric demyelinating diseases in terms of its pathophysiology, discovering new antibody markers like NMO and MOG, and development of targeted treatments like the disease-modifying therapies. So, pediatric demyelinating disorders can be classified into two broad groups for ease of understanding. The one group is called monophasic and includes ADEM, clinically isolated syndrome, anti-MOG associated disorders. And the second is multiphasic, which includes POMS, NMO spectrum disorder, and again, anti-MOG associated disorders, which can be both monophasic and multiphasic. However, it must be remembered that it is entirely possible that what appears to be a monophasic episode can represent the first attack of a multiphasic disorder. So for today's talk, I'm going to concentrate on the three big topics: pediatric onset MS, ADEM, and NMOSD. MS is now being diagnosed in increasing numbers in children and adolescents. And if you look at the percentage, about 2 to 10% of all MS cases have an onset before age 18. And younger patients under 11 make up only about 0.3%. In terms of epidemiology, there are several microorganisms, including EB virus, HHV6, and chlamydia, that have been implicated in the pathogenesis of MS. But the evidence has been equivocal, except very recently for EB virus. A paper by the Mass General people and subsequently by the Stanford folks published their series of papers showing EB virus not only to be a trigger, but some people would think it is actually the cause of MS. There is also convincing evidence for vitamin D deficiency and increased risk of MS, as well as low iron levels and obesity. In PEDS patients who are less than 10 years of age, the female is to male ratio is 1:1, and in those more than 10 years of age, the ratio tilts towards more females than males. And a family history of MS is reported in a significant percentage, about 5 to 15% of affected children. Clinical features, the signs and symptoms of MS, important to remember, are not preceded by a viral prodrome as seen in ADEM. And the common symptoms include sensory deficits, optic neuritis, pure motor paresis, cranial nerve or brainstem syndromes, gait disorders, including ataxia. Those are the common ones. The less common ones would include headaches, seizures, and very rarely encephalopathy. So if you have a patient with encephalopathy, it's most likely ADEM, but keep in mind that MS can sometimes present with encephalopathy. And other symptoms and signs would include a big percentage of patients with cognitive disability, fatigue, psychosocial problems. Lemaitre and Uthoff's phenomenon, as seen in the adult MS patients, is rare in children. What about disease course and outcome? Over 95 to 99% of POMS patients are relapsing, remitting type of MS. A primary progressive course is rare. It's about 2.3 to 7% compared to 20 to 30% reported in the adult population. And up to 60% of pediatric onset MS patients relapse during the first year, much higher than in the adult onset MS population. In terms of diagnosis, there is no single pathognomonic test or a clinical feature for the diagnosis of MS. So misdiagnosis is often common. And in adults and children, think of NMO spectrum disorder, because in any patient being evaluated for MS, you must exclude NMO-SD because the treatment of these two conditions are different. And also in children, differentiation from ADEM can be challenging. And the diagnosis of MS relies on a number of features, clinical features, imaging, and lab findings. Blood, MRI, CSF, dilated eye exam. And we look at blood tests. The classic features on blood tests that we look for are vitamin D, EB virus titers, iron levels. We always perform aquaporin 4 and anti-MOG antibodies to rule out NMO and anti-MOG demyelinating disorders, respectively. What about imaging? MRI brain. We usually would include MRI brain and cervical spine, with and without contrast. Occasionally, if there is features of optic neuritis, we would add the orbits and thoracic spine. What about CSF? CSF is important for two main reasons. Intrathecal antibody synthesis, so we're looking for elevated IgG index, and in my series of patients at the Cleveland Clinic, 77% of them had that feature. Secondly, oligoclonal bands. And in my series, 72% of the patients had that, whereas in adult patients, the percentage is more than 95%. So if you have 2 or more CSF-specific oligoclonal bands, that indicates there has been intrathecal antibody synthesis. In adults with clinically isolated syndrome, CSF oligoclonal bands are independent predictors of a second attack. So that's important. Keep that in mind. So if you have CSF and it shows elevated protein more than 100, pleocytosis more than 50, presence of atypical cells, that suggests another diagnosis besides MS. Let's go a little about McDonald criteria definitions, which you would see in your reading. We use 2 phenomena here: dissemination in space and dissemination in time. What does dissemination in space mean? The development of T2 hyperintense lesions in distinct anatomical locations within the CNS. And these locations are juxtacortical, periventricular, infratentorial, and spinal cord. In the 2017 revised McDonald's criteria, they added cortical lesions as well. Dissemination in time, the development or appearance of new CNS lesions over time. That's what it means. And if you have simultaneous presence of GAD enhancing and GAD non-enhancing lesions in any time in the same picture, that satisfies the criteria for dissemination in time, because one is enhancing, one is not. The 2017 McDonald's criteria also emphasized the contribution of CSF analysis. And in individuals with just one attack, if you have oligoclonal bands in the CSF, that can substitute for demonstration of dissemination in time. So oligoclonal bands satisfies dissemination in time. Here's a FLAIR image showing classic picture of MS. You see periventricular lesions, you see deep white matter lesions, subcortical lesions. And on my right, you see a sagittal FLAIR, which shows lesions that are all over the corpus callosum, and some of them are finger-like projections from the corpus callosum into the deep white matter. And these are called Dawson fingers, and they're classic for MS. Okay, what about dilated eye exam and OCT? These two are very important investigations for pediatric demyelinating disease. Now, optical coherence tomography is a non-invasive imaging tool, and it uses light waves to take cross-section pictures of the retina, and it helps to diagnose optic neuritis secondary to MS and NMO. MS and NMO OCT is very important. Optic neuritis in NMO typically results in more severe retinal nerve fiber layer and ganglion cell lining thinning than MS. So people who use this often can actually tell you this OCT is that of NMO spectrum disorder and this is MS. So important to include this in your diagnostic armamentarium. What about differential diagnosis of MS? Other inflammatory demyelinating conditions, infectious diseases, collagen vascular disease, genetic metabolic disorders important in pediatric patients, and mitochondrial disorders. Vascular disorders like moyamoya, CADASIL, and vasculitis, neoplastic, especially lymphoma, and astrocytoma, and miscellaneous conditions like thyroid, B12, folate, neurosarcoidosis. What about treatment? Treatment is divided into two groups: acute treatment and maintenance treatment. Acute treatment for MS includes IV methylprednisolone, 30 milligrams per kg per day for 5 days, with a maximum of 1 gram per day, followed by a slow taper over 2 to 4 weeks. If there is poor response to steroids, we transition immediately to IVIG, plasmapheresis, or the new agent rituximab. Maintenance treatment would include the following agents. Oral agents, we use Tecfidera and Fingolimod. Fingolimod is the only FDA-approved oral medicine so far. I use a lot of Tecfidera and have had excellent response. And if you want to use injections, you can use rituximab infusions, interferons, Avonex, and Rebif, and Copaxone, glaturamin acetate. Okay, so that's the end of MS. And now the second demyelinating disease is acute disseminated encephalomyelitis. Definition: it's a first polyfocal CNS event which has an inflammatory demyelinating cause. Typically, it occurs 2 to 3 weeks following a viral infection. The presence of encephalopathy and MRI abnormalities consistent with demyelination are required to meet the diagnostic criteria. That is very important. Encephalopathy and the MRI changes. ADEM rarely represents as a first attack of MS in children. But remember, it can represent the first attack of not only MS, but also NMOSD and MOG-associated disease. So keep that in mind as well. Symptoms: these can be preceded by fever, nausea, headache, and vomiting. ADEM progresses rapidly over the first few days, and classically, ADEM is a monophasic event with no new disease activity after 3 months of disease onset. But there is a type of ADEM called multiphasic ADEM. This is defined as a second ADEM event that occurs more than 3 months after the last event. Now, ADEM can also be followed by optic neuritis, and that's called ADEM optic neuritis, or it may be the first presentation of NMO spectrum disorder. And as I mentioned earlier, ADEM usually is not the harbinger of pediatric onset MS, but it can be followed. If an ADEM event is followed by a non-ADEM event that meets criteria for MS. So it can be harbinger of MS, but it has to be followed by a non-ADEM presentation. Okay, that means no fever, no encephalopathy. A fulminating form that requires admission to ICU and mechanical ventilation are 2 serious forms of ADEM, including hemorrhagic ADEM. And hemorrhagic ADEM is sometimes associated with influenza A and B infection. Laboratory testing, hematological biochemical tests as noted there, including anti-aquaporin 4 and anti-MOG antibodies. And then look at the CSF for white cell count, look for oligoclonal bands, and look for IgG index. Always look for autoimmune encephalitis as well in patients with ADEM. Neuroimaging, here's a classic image of ADEM showing lesions in the cortex, deep white matter, and in the subcortical white matter, and they are asymmetric lesions as well. Remember, spinal cord involvement is seen in 30% of patients of ADEM, and contrast-enhancing lesions are also seen in about 30% of patients. Here's another patient, 60-year-old child who presented with fever, headache, nausea, and gait ataxia. And on MRI, you see on my right, the sagittal image showing lesions in the midbrain, pons, and the medulla. And 5 days after steroid, IV methylprednisolone sessions, the lesion has almost disappeared with just a residual lesion in the midbrain. What about treatment? So we start with 5-day course of high-dose IV methylprednisolone at that dose, followed by oral steroid taper over 4 to 6 weeks. The dose for the taper is 1 milligram per kilogram per day, and then we half the dose every 5 days. In refractory cases, we may immediately transition to IVIG or plasma exchange. What about outcome? Typically, neurologic improvement occurs within days of initiating steroid treatment, and recovery from an ordinary ADEM attack is back to baseline in a few weeks. Rarely, some children develop multiphasic disease, which can lead to multiple sclerosis, NMO spectrum disorder, or anti-MOG associated demyelinating disease. Okay. This is my last talk. It shouldn't take too long. The NMO spectrum disorder. This is a spectrum of demyelinating disease distinct from MS. It is characterized by 2 classic features: optic neuritis and longitudinally extensive transverse myelitis. In 65% of cases, there is a positive NMO antibody in the serum. In 10% of patients, anti-MOG antibodies are detected. And in 15%, they are seronegative for both NMO and anti-MOG. The clinical features: it's a highly relapsing disease, and there is a relapse rate of about 1.8 attacks per year. Most common presenting symptoms will include optic neuritis. They can be unilateral or bilateral, predominantly unilateral, transverse myelitis, and area postrema syndrome, very characteristic for this condition. And they present with vomiting, constipation, and intractable hiccups. Rarely, they may present with features of narcolepsy and sometimes with symptoms of PRESS. And laboratory testing like ADEM, hematological biochemical testing, including anti-MOG and aquaporin 4, CSF, including IgG index and oligoclonal bands. Remember, 30% of patients with NMOSD have oligoclonal bands. Neuroradiology, you can do MRI of the brain, orbits, and spinal cord, rarely lumbar spine. And miscellaneous tests like MS, you can do a dilated eye exam and OCT. Here's a patient with longitudinally extensive high enhancing lesions involving the medulla, upper cervical, and lower cervical region. And on my right is optic neuritis shown by the red arrow. Okay, the management of NMOSD includes treatment of acute attacks and preventative therapy. The acute attacks, you have to be very aggressive in the management of relapses in this condition. Again, you use IV methylprednisolone at 30 milligram per kg per day. If no improvement and or worsening symptoms, immediately go to plasmapheresis, TAM5 cycles, or you start rituximab. Plasmapheresis is often initiated before IVIG in children with NMOSD, as early initiation has shown improved outcome in severe attacks in adult NMOSD. Preventive therapy or disease-modifying therapy used to decrease the risk of relapse and associated disability. First-line DMTs in children for NMOSD include mycophenolate mofetil, azathioprine, and rituximab. These are the three classic preventive medications for this condition. I thought this is going to be important for people that are taking care of patients with NMOSD. What medications to avoid? Because if you don't, you can make the condition worse. Interferons, glatiramer acetate or Copaxone, dimethyl fumarate, Tecfidera, and alemtuzumab and natalizumab. These are all agents that can make NMOSD worse, so don't use these in patients with NMO. Now, my last slide, take-home points. 1, the signs and symptoms of MS are not preceded by a viral prodrome. That is ADEM. Encephalopathy is a required symptom for the diagnosis of ADEM. Thirdly, all patients being investigated for demyelinating diseases must have an aquaporin 4 and anti-MOG antibody testing. NMOSD must be considered in all patients being investigated for pediatric onset MS, as their treatments are different. Okay? And remember, medications to be avoided in NMOSD. I'll stop there. Thank you. I can take any questions.
So with many immune disorders in adults, there's a corresponding neonatal syndrome. You know, like if you have a 25-year-old woman during pregnancy who has an immune disorder, do you see babies with symptoms when their mother has things like this?
I didn't get your question. If the mother has symptoms,
If the mother has the disease and delivers a baby, does the baby have symptoms ever?
no.
Why?
Not sure why, but they don't. Okay. Any other questions?
When you say that you, especially the NMOSD and in ADEM, you mention about lack of response after the IV Solumetrol. What is the timeline that you give for a response after 5 days of treatment? Do you give it immediately as you're treating, or a few days, or before you engage in the higher level of
Yeah,
treatment?
that's a good question. Within 2 to 3 days is the consensus. If you don't get a good response within 2 to 3 days, you immediately go on to rituximab in the case of NMOSD. IVIG comes later. After rituximab, you may go on to plasmapheresis. So plasmapheresis, rituximab before IVIG.
So that means you need to see a clear change in the exam findings in 2 days.
You're supposed to see a significant change in the first 2 to 3 days. If you don't waste time for 5 days. Go immediately plasmapheresis or give rituximab.
Thank you.
Does pediatric onset multiple sclerosis ever go into remission, or is it guaranteed to be a lifelong disease once that diagnosis is confirmed?
That's a very good question. Nobody really knows the answer. But I've been reading about burnt out cases of MS, and I did have such a case at the Cleveland Clinic where the patient had MS on treatment for several years, must have been about 6 or 7 years, and thereafter didn't need any more treatment because the subsequent MRIs were burnt out. No new lesions for several years. And I've just been following that patient up. So the adults in the group may know more because we give treatment for pediatric onset MS throughout the course of their stay with us, which is up to 18. But thereafter, I'm sure some of these patients do get burnt out. And I'm not sure how long they give the treatment for as well.
Dr. Moodley, we have a question in the chat. A wonderful talk, thank you. Dr. Hager is asking, we have had bowel perforation as a part of NMO-related encephalopathy. Are these receptors everywhere?
They're not everywhere. They classically in areas where there's an aquaporin 4 channels, and these are in the hypothalamus, periventricular area, and in the spinal cord. That is why you find lesions periventricularly, hypothalamic, brainstem area, and spinal cord. In the bowel, the bowel has a lot of innervations, and they could be because constipation is a big issue in NMOSD, and also I haven't heard of bowel perforation, but constipation, nausea, vomiting is common. Hiccups is common, but that is area postrema syndrome. It's in the brain stem that the problem happens and manifests elsewhere. And very rarely you might get symptoms of press or narcolepsy. They're very uncommon, but keep that in mind because that might give you a clue to that this patient's demyelinating disease is probably in the mole. Okay, thank you.
Our next speaker is Dr. Veda. Dr. Veda's been my friend and colleague for a few years now. Dr. Veda is a native of India, but trained in child neurology at Duke University, followed by neuromuscular disease fellowship at Johns Hopkins. He joined our program here a couple of years ago and has already built an outstanding and very, very busy neuromuscular disease program. He's going to talk to you today about primary care issues with muscle disease, neuromuscular disease. Thanks.
So what I'm going to talk about is some of the primary care issues that face children who have neuromuscular disease. Now, as we all know, neuromuscular disease is a chronic medical condition, and with recent progress in multiple areas, including gene therapy, the survival of these kids is being prolonged, and they are beginning to engage in more activities that was previously not a big issue. One of the good consequences of this is that as primary care physicians, they get to see several of these kids for multiple reasons. And what I thought is I would address what, in my opinion, would be some of the important primary care issues that would come up to a practicing pediatrician in their busy practice. So I have no relevant financial disclosure in relation to this talk. So my talk will address these 5 important areas. First, I will try to talk about some of the red flags that can be detected in clinical practice. And the second, we'll also address what are the issues and questions that come up in terms of childhood vaccinations for these kids. And third, as pediatrician, we are always concerned about growth and nutrition. What are the issues that are somewhat different and important in neuromuscular patients? And this is very critical for pediatricians who are taking care of patients in the hospital setting with acute illness and as after surgery in terms of some of their unique issues and medical problems. And lastly, quite important is what kind of restrictions generally we should ask these children what kind of restrictions should be given to these kids in terms of school activities. So I'm going to start with a case, and this is just to emphasize that quite often as practicing pediatrician, you're likely to see this. So here is a 5-year-old boy who comes in with a delay in language and social skills. When the pediatrician examines, notices that he's a bit clumsy. He was fumbling, and, stumbling and falling more often. And for some reason ended up with getting a metabolic panel, and there we had elevated liver enzymes, AST and ALT, which is quite significantly, But then we also see that the bilirubin and the albumin, they're quite normal. Now, in the past, when I started practice, we used to have gamma GT as part of the liver panel, and these days they don't include that. So this child got referred to a gastroenterologist because of persistent elevation in transaminases. And then, of course, the GI doctor went ahead and had a viral panel, which was normal for hepatitis, a liver ultrasound, and then even a normal liver biopsy. So this all ended up several months of workup. And eventually, the hepatologist felt that this is probably not liver. And then a CPK was done in the neuromuscular clinic, and it was 7,800 international units, clearly about 40 to 50-fold higher than what it should be. That led to genetic testing for dystrophin disease being the most common in this setting, in this age group, showing that there was a deletion of exons 45 through 51, fairly common pattern, and a diagnosis of Duchenne. So the point in this is that many times we get misled by some of these lab work, and we should actually focus more on clinical exam findings that would be of more value. Let's see. This one. It's not moving. Okay. Huh? No, I'm looking for the slide move. Next slide. Okay. No, sir. Oh, okay. All right. So this is a oh, you just go up on the upper end. Okay. This is an important kind of slide. This is a slide that summarizes the findings of by a fairly large WHO-sponsored study to evaluate developmental milestones. So here we do find that when this is a group of almost 600 children from multiple countries. And what we find here is on the little box, it's the 95th percentile when the children should achieve their motor milestones for different criteria. You should be able to sit by without support by about 9.5 months, stand unassisted by 12 months, crawling by 14, walk assisted by 14.5, stand alone by 17.5, and walk alone at 18. So anything that's beyond this and you don't have a clear explanation for the delay, such as prematurity, or it should trigger at least a concern for muscle disease. Okay, the other scenario that comes up in pediatric practice is seeing a floppy infant. So quite often the question comes up is this floppy infant floppy because of brain-related disease, or is this floppy because of muscle or neuromuscular-related problem? So these are some of the easy clinical points that can be elicited and can help in differentiation. So if the tone is decreased both in the muscles of the trunk and limb, it's more likely to favor a central cause, meaning brain. If the tendon reflexes are preserved or hyperactive, they go more in line with central. Whereas if they are hypoactive or difficult to find, more often, you should consider that it could be coming from a neuromuscular reason. Encephalopathy, meaning the child is not alert and attentive and appears, versus a child who is hyper alert, appears very normal. That favors more a neuromuscular reason. Persistence of reflexes that you would expect to be gone, such as Moro's asymmetric tonic neck response and grasps, that should lead to concerns for central cause versus its absence favors peripheral. And then if you're happening to see this child over, say, a few months, the evolution is also important because in general, when low tone and weakness is seen from central reasons, it often will move on to having hypertonia over time, versus here the muscle weakness will persist and would expect to increase in severity. So I'm having time with or can I just ask you to change or when I come to the next slide? Okay, so what are some of the important clinical clues that I use and probably can be used in any pediatric is delays in or regression in motor milestones. We talked about the salient 6 points. Low muscle tone or imbalance in a child, especially one that's progressing or of new onset. Numbness, if the child is complaining of it persistently, and you can elicit lack of sensation. Loss of tendon reflexes is important clinical finding, or absence again, and that should lead to concern for muscle or neuromuscular disease. I like to sort of point out abnormal liver function studies in healthy children should always also be a concern before going to liver biopsy to consider doing a muscle enzyme test in that setting. History of pigmenturia. There's children who after exercise end up having urine that's of tea color or very dark. It should also be considered for muscle. Unexplained fatigue and paralysis after physical exertion. And the most important thing is muscle pain is not a very specific complaint for neuromuscular disease. There are very few muscle disease that truly come in with muscle pain. Usually it is in the context of toxic myopathies, which is more common in adults. Even your inflammatory myopathies, even though you have weakness, the pain comes more from joint and other issues, not specifically muscle related. Muscle pain is important when it's with exertion, when it triggers the possibility of metabolic myopathies. Next slide, please. So some of the useful laboratory studies that can be done in primary care setting is when you suspect muscle weakness, you could do a serum creatine kinase, vitamin D levels, serum electrolytes, and then when your principal complaints are more with numbness and tingling, be sure not to forget vitamin deficiencies, B12, folic acid. Copper is often missed, but it keeps company with the same B12 folate deficiency. You present more or less similarly as far as the neurologic condition, because thiamine is an important thing, especially in children who are hospitalized and who are maintained NPO for days together. It can be rapid in onset, presenting with, I think I've seen here 2 cases of thiamine issue, one with Dr. Moodley and one recently. So it's not uncommon. It does happen, and it should be kept in consideration. B6, quite uncommon. And children, you could also, especially in the right setting, if the kids are heavy set, screen for hemoglobin A1C. Diabetes can present with numbness, paresthesia. Thyroid function studies is a critical and important part of all neuromuscular evaluation. Next slide, please. So shifting gears, we'll come to the next big question in primary care is, what do we do with vaccination for children with neuromuscular disease? So the general consensus that children with neuromuscular disease should receive recommended childhood vaccinations. There's no restriction for any of them. You have to keep in mind that if a child is immunosuppressed with medications such as steroids or other, then you don't want to expose them to live virus vaccination, which would include measles, varicella, nasal influenza. Live polio virus vaccine is an issue in in tropical countries, in India and South Africa, not an issue. So these should not be given to children who are immunosuppressed. Inactivated vaccination can be given to all kids who are also on immunosuppressive medicine, but need to bear in mind that the response will not be robust. So if you protect them, it does not mean that you are completely off the, risk is not completely mitigated. So you can still get a modified response. If the child is in a setting where you know that in the near future you're going to immunosuppress, then it's a good idea to, actually expedite the vaccination regimen, sort of combine, instead of giving them spread out, sort of bringing them together. And also one other thing is that when you complete the immunotherapy for, say, a certain length of time, consider revaccinating. So that because the response will not be good while you vaccinated, the child was on the immunotherapy regimen. Next slide, please. So the common immunotherapy that we use in pediatric neuromuscular patients these days is in spinal muscular atrophy, we use oral and high-dose steroids, especially when they have a reaction to the gene therapy. And this is so generally for the first 4 or 5 months or even longer, depending on how their autoimmune response is, you have to hold back on the life. Duchenne children will be on immunotherapy, almost all of them after the age of 5 or even early in 3. And that includes either prednisolone or deflazacort. Inflammatory muscle disease, we have a whole issue of steroids, IVIG, Rituxan, and Imuran. Similarly, for inflammatory neuropathies like Guillain-Barré syndrome and other, in the context of autoimmune, like lupus and mononeuritis, you would use a whole host of them. Myasthenia gravis does occur. I think it is, we see at least 2 patients a year or so of childhood myasthenia, and they remain on, for a long period of time, on immunotherapy. Next slide, please. So when you have children who are immunosuppressed for neuromuscular disease, you may have to consider additional immunization. And so the most important one that I emphasize and I try to check on, and it's important, is that their Pneumovax status is up to date. This would help with preventing community-acquired pneumonias. Influenza vaccination should be given as appropriate. Meningococcus should be administered, plus for certain types of immunotherapy medicines, especially complement 5B inhibitors. If you're going to use meningococcal vaccination, it's essential. Revaccinate after immunosuppression is over. We kind of talked about this. There's no contraindication for COVID vaccination for neuromuscular patients. And also, there's absolutely no data about the recent influenza vaccination increasing risk for neuropathies. So you could freely and give all kids with neuromuscular disease should be immunized for influenza. Next slide, please. The growth and nutritional issues are another big area that's important for these children. We have both ends of the spectrum of problem. We have children who would be low and failure to thrive, and then you would have children who are obese and at the other end. Underweight is fairly common when children cannot swallow or have GI issues, and then excessive weight when they lose ambulation and get in the wheelchair. Short stature and slow gain in height is often seen in many neuromuscular conditions, and many times we accentuate it when we use steroids and immunosuppressive therapy. And delayed puberty is an important factor, especially in males, because it is important for muscle growth and also for bone health. And that needs to be addressed appropriately. And especially in Duchenne boys, it is an important criteria that we monitor and try to get them on testosterone treatment if they are delayed consistently. Vitamin deficiency is very common, especially D. Then others that are commonly we do see is iron, B12, and folate. My practice, I always check this at the first initial, and every 6 months or so, I try to look for vitamin deficiency because this is quite easy to correct. Next slide, please. Now, one of the things, this is a picture I just showing here that what you see on the dark line and there's a faint line above it, this is just patients with spinal muscular atrophy, and it shows how the growth curves are different. The faint line represents the normal, normative data for children, and then the dark lines are the ones for the spinal muscular atrophy. The one on your left-hand panel is SMA2, right hand is SMA1. So what you see is initially they seem to follow along with the course, and then you see them sort of flattening out and falling off. And we are beginning to use this more often now in terms of making a determination as to whether they are overweight or not. Next slide, please. The vitamin deficiency, D is the most common. It can also accentuate or make your muscle disease symptoms worse. And also there is a vitamin D myopathy, though not very. And then B12, folate, copper causes polyneuropathy and a myelopathy. Thiamine with polyneuropathy and Wernicke's disease. Pyridoxine if it's a small fiber neuropathy, but usually when it's high dose, but not very common. Vitamin E myopathy, the most important subgroup here we think about is children with cystic fibrosis and malabsorption disorders. And similarly, L-carnitine. So there is value in testing for these when children come in the primary care setting with muscle symptoms, because these are easily correctable. Next, please. So bone health is another very critical and important area, which for children with muscle disease, they already have a high risk for bone loss because of lack of physical strength and activity. Compression fractures of vertebra and non-displaced fractures are common. Muscle weakness, actually, and loss of ambulation, undernutrition, and also vitamin D deficiency are important factors. We have to screen these children with a high index of suspicion. We are doing it more now than before. Bone density measurements are not done very routinely, but it is becoming standard of practice for children with muscle disease. And the problem is still in terms of how to deal with this. High-dose vitamin D is generally the approach we take, but the role of biphosphonate therapy is still controversial, and it's being studied. There are some recommendations stating that IV forms of biphosphonate therapy is better than the oral daily, weekly forms. Next slide, please. So this is a picture that shows you on the left-hand side a vertebral compression fracture. It's on the You could see it's on the L4 vertebra as a consequence of osteoporosis. And on your right-hand side is the bone density measurement. And you could see that on the small box, which says age 68, it's osteopenia. That means it's the one grade before osteoporosis versus the next one where the bone is very, has lost of its bone substance. And this is something that we are doing now. We at least try to do it every 2 years in children with Duchenne. It's one of the monitoring that we are beginning to do for these children. Next, please. Okay. Now, I'm just showing you this picture because this is a study from the endocrine group in Children's Hospital in Birmingham, which was published in 2015. And what this is representing is a group, there's a group in Europe who are monitoring bone health and bone-related issues amongst the endocrinologists. And there is a recommendation for providing infants with vitamin D supplementation. So what this is showing you is the percentage of compliance with vitamin D supplementation. And what you see here is the blue is better compliance, yellow is lower than that, and red is bad. So UK has a large population, especially immigrant population, who are do not get the adequate amount of vitamin D and the consequences of this. And that pretty much apparently follows what's known in terms of what's happening in the United States as well, that it's quite a rampant issue with low vitamin levels in children. And this additionally makes bigger problems for children who have neuromuscular disorders. Next slide, please. So what do we do in acute illness? Some of the things. So if the children are immunosuppressed, naturally they're going to be more at risk for infections. And similarly, respiratory infection will push a child who is on the brink to a respiratory failure. So early detection of infection, cold, common cold, aggressive pulmonary toilet, sort of respiratory management should be considered. And this may come across in the primary care office. Children with neuromuscular disease have low muscle bulk, so they do not tolerate starvation very well. So that's the important thing. And they have higher incidence of hypoglycemia, hypokalemia, because the muscle mass is low, and their ability for gluconeogenesis is very limited. So keeping that in mind, these children perhaps need to be resuscitated with fluids and not allow prolonged periods of starvation, preparing for surgery or thereafter. Stress dose of steroids is an important thing. It should be administered in acute infection, post-surgery, trauma. And this need can be even for many years after the immunosuppressive therapy is stopped. So the best and safe way would be that if a child has been on immunosuppressive therapy with steroids, is to really give the child stress dose of steroids before surgery and during a stressful, because it's going to be protective. And lastly, antibiotics are bad in certain circumstances. In myasthenia gravis, aminoglycosides and fluoroquinolones and macrolides can cause a problem. It can worsen the symptoms. So in your choice, need to bear that in mind. Similarly, in polyneuropathies, medications like metronidazole and fluoroquinolones, INH, they can make your neuropathy considerably worse. I've seen in adults fluoroquinolones push myasthenia patients to crisis just from one dose. And similarly, I have seen severe small fiber neuropathy after like 1 or 2 doses of fluoroquinolones. Next slide, please. In terms of sporting activity, many things are fairly easy to understand or realize. Children with muscle weakness are at higher risk for injury. So we generally recommend aerobic activity, walking or swimming, tennis, that sort of thing. Strongly discourage contact sports. And children who are at risk for rhabdomyolysis, these are usually the most difficult situation. You have children who have had a history of rhabdo, and these are the strong kids in the football team, the parents, the coach, and everybody wants to play, and you have to be the bad person saying, no, you cannot, because you're at risk for having another severe episodes of rhabdo, especially in heat and strenuous exercise. And then, of course, fall precautions with muscle weakness is an important factor, and the schools should be aware of this and perhaps take adequate precautions. So I'm going to stop with this, and we'll be happy to answer questions. Thank you very much for your attention. Okay.
Thank you, Dr. Veda.
Sure.
What do you see as any new emerging issues now with the gene therapy for SMA? Any particular emerging issues related to primary care now that survival has increased?
I see it in two ways. One, early detection, which of course in our current state with the policies, the newborn testing will pick up. But pediatricians need to bear in mind that 5% of children with SMA will be missed on the newborn screening. And these are the kids who have what we call it the double heterozygous mutation instead of homozygous. So even now, even though it is going to be considerably less likely, bear in mind that when you have floppy small babies, we want to evaluate them for that. Number two, when we treat these children with gene therapy, the big issues we do see is reaction against the virus. So their immune system gets overactivated and they have to be on steroids. And this can vary most often for about 6 to 8 weeks in the best scenario. And in some scenario, it could last for several months and could include also high-dose steroids, plasmapheresis, and rituximab. So those children would be, again, at high risk. But once these are dealt with, I think the rest of them will depend upon how much residual weakness they have. So if they have moderate amount of weakness, they, of course, will go through the standard approach of pulmonary evaluation and pulmonary, airway clearance and airway support. Yes?
So gene therapy has just totally revolutionized SMA, of course. I mean, it's gone from a horrible disease to, we hope, curative. Two questions. One is, in your estimation, is a single gene therapy administered at a few weeks of age, is it going to be a lifelong thing or is it going to wear off? That's one question. And the second is, what's the status of gene therapy for other neuromuscular disease?
Coming to the first question, I think the earlier the gene therapy is administered, the more robust is the response. So children who get them in the first month, which is they are more likely to have a better response. In terms of what is how long will this last, it's still an open question, but people think it may be for many years or could be even, for the rest of their lives. There are some who have had gene therapy where the timing is such that it was delayed for a variety of reasons, 6 months or even up to a year, because you could give this tech by the FDA standards, you could give gene therapy up to age 2. So if it is delayed further, then the likelihood or the response is not as robust. And then you do see instances where there is recurrence and weakness. In those circumstances, now we are treating them with the other treatments, which is nusinersen, which is anti-ASO, antisense oligonucleotide therapy, or with the small molecule risdiplam, which again will repair. Now, there's a study that is in progress to really answer the question, how long will they last? But the general consensus is, if you treat it real early, the likelihood that it's going to last long, versus there have been instances, at least I have one patient who got that fairly late, around close to 14 months or so, didn't really see any real benefit from it. He got the gene therapy, didn't really improve, and then had to be on the nusinersen. In terms of the second one, for Duchenne muscular dystrophy, it looks like it's going to be very soon the gene therapy may become available. There are two, one study which is going through right now, it's called Embark, and what they're doing is they're looking at children between the ages of 4 and 7 for gene therapy. It was earlier done, but what happened was the stratification was a little off mark, meaning they stratified them based on age and didn't really stratify them based on functional capacity. So the results didn't pan out. But when you compare with historical controls, there is a benefit. So now the next phase is where they are stratifying them based on their function, and it should be fairly in about a year or so we'll know. But it's going to be coming up soon. And the next study that is in works where there is to treat children who are non-ambulating to preserve function and their cardiac function as well. The other one, which is we do have treatment trial with gene therapy, is for myotubular myopathy. There was a little issue because they failed to recognize that it can cause liver disease, and now it's being brought into consideration. And then gene therapy is also will be available fairly soon for a trial for Charcot-Marie-Tooth disease. And also there's one Charcot-Marie-Tooth type 2 called GDAP, which is glial-derived protein, which is important. And that particular one is also progressing well. All right.
Thank you very much, Dr. Veda. Excellent. Our next speaker is Dr. Stephen Deputy. He's our newest neurology faculty member here at Dell Medical School. Stephen joined us in January, I believe, after completing his training in child neurology at the University of San Francisco, or University of California, San Francisco, UCSF, and has spent most of his career until joining us in New Orleans, where his concentrated interests are in medical education, curriculum development, and from a clinical standpoint, movement disorders. He's going to update us today on tics and Tourette syndrome, right? Thanks.
I'm happy to be here. I think this talk, or not the talk, but the topic is very important for primary care pediatricians because tics are common. You're going to see them. You're going to see them, a lot of them. And what do you need to do with them? How do you counsel people that have tics? Hopefully we'll have some answers for you at the end of this talk. Right now, I don't have any relevant disclosures, so we'll just skip over this. So we want to be able to differentiate different tic disorders. We want to be able to counsel people to understand the natural history of tics within Tourette syndrome. There are an awful lot of neuropsychiatric comorbidities in most people with Tourette syndrome, and I think these need to be identified and recognized. As we'll find out, they often are causing much more psychosocial disability than the tics per se. We need to prioritize which features of Tourette syndrome need to be managed initially to come up with a treatment plan, and then we'll talk a little bit about some of the principles behind pharmacotherapy and comprehensive behavioral intervention for tics, which is a habit reversal therapy. So what are tics? I think we all can see them, we recognize them. The definitions are, they can be motor or they can be vocal, but they're rapid, repetitive, non-rhythmic, stereotypic. If you see one tick, you see the next tick, you see the next tick. They're always the same, right? The individual tick doesn't change. They can be these movements, but they can also be vocalizations. They often occur in bouts. They wax and wane in frequency, intensity. New tics replace old tics. Old tics can come back. We can have multiple overlapping tics. So they're very dynamic in that fashion. The other thing about tics is that they can often be temporarily, voluntarily suppressed unless they're very, very severe. So somebody may bring their child into the office and say, I think my child has tics, and you won't see any in the office. That doesn't mean they don't have tics. Another factor about tics in older kids is there may be a premonitory urge, a sensation internally that occurs just prior to the tic being exhibited. And this is going to be important when we talk about the habit reversal therapies. So motor tics arise with involuntary musculature. Think about head and neck regions. Tics usually begin with eye blinking is really common, or eye darting movements, or facial grimacing, or head jerking movements. Same thing with the simple vocal tics. They're going to be repetitive sniffing, repetitive throat clearing. Well, there's a lot of kids that have allergies. They sniff, right? So what differentiates that? Sometimes it's tricky, but one of the things about tics I always tell people is that they're things that we all do. We all sniff, we all blink our eyes. But if it's repetitive and excessive and it's not serving a function, that's what makes it a tic. And the other thing you can do with tics is that they're not going to be there for a week and go away. They're going to wax and wane, and they're going to become more prevalent when there's stress or excitement. So those are some clues as well. This is just a little side thing, but we've been seeing these functional tic disorders lately. And these are kids that are exploding with these very complex motor tics and vocal tics and coprolalia out of the get-go within a few days. Tics and Tourette's don't do that. They start off in the face, and then over months or years, they can progress down to the extremities. So that's something to keep in mind as well. The motor tics are basically, the vocal tics are anything that comes out of the nose or mouth. So sniffing, guttural sounds, humming, hooting, little noises, up to complex vocal tics, which are formed words, and then we have this coprolalia, right, where we're shouting out curse words. Well, one of the misunderstandings of Tourette syndrome is that coprolalia isn't required to make a diagnosis of Tourette syndrome, and in all patients with Tourette syndrome, no more than 10 or 15% ever experience bouts of coprolalia, so it's fairly rare in Tourette syndrome. All right, so once we've identified that a child is having motor or vocal tics, then we need to look at what is the classification of their underlying tic disorder. So we have a kind of a hierarchical pattern, and I think the best way to think about things is we have a transient tic disorder or a provisional tic disorder. By definition, means that the tics have been present for less than 12 months. Chronic tic disorders, by definition, mean they've been present for greater than 12 months. But as you can probably recognize, everybody with a chronic tic disorder at some point in their tic history was going through a provisional tic disorder, right? So one of the things I think I like to try to do if I see somebody who's only had tics for less than a year is I want to help the family understand what's the likelihood that this is going to become Tourette syndrome versus what's the likelihood that this is going to remain a provisional tic disorder. So that's something to think about as we move forward here. If we look at the frequency in the population or the prevalence, as many as 1 in 5 children experience tics at some point in their life. 20%. That's a lot of kids. That's why you're going to see them in the pediatrician's office. But if we look at the prevalence of Tourette syndrome, you'll see it's much less common, 1 in 150 or so. So the vast majority of kids that are presenting with tics are going to have provisional tic disorders. And I think that's important to counsel the families with. So the definition for Tourette syndrome is that you have to have multiple motor and at least one vocal tic off and on for greater than a year. The tics are going to wax and wane in frequency and severity, as we mentioned. Age of onset needs to be before 18 years, but often is much earlier in life. And the tics are not caused by a secondary disorder, which are rare, but disorders that we have injury to the basal ganglia, things like Huntington's disease, people that recover from encephalitis, autism, interestingly. About 30% of kids with autism have tics. So I don't call those people having Tourette syndrome and autism. I say they have tics within their autism disorder. There's gender influences. There seems to be a strong male to female influence in chronic tic disorders, but also in the provisional tic disorders. And within the chronic tic disorders, there is an increased background family history of other people, first-degree relatives with tics. That's much higher than in the general population. There's not a gene that has been identified that causes Tourette syndrome. It's been looked for. It runs in families. It's multifactorial. It's a mess. They keep looking and looking and looking. They can't seem to figure it out. But it's very common to ask if there are other first-degree relatives or second-degree relatives that have tics. So one of the things to counsel families about are what's the natural history of tics and chronic tic disorders? Well, the peak age of tic recognition is usually early school age, although if we look at studies and we go back in time and we maybe that wasn't allergies, or maybe that child didn't have allergic conjunctivitis, and maybe that eye blinking when he was 2 or 3 years of age was tics. They can occur in toddlerhood or occasionally in infancy. The tics start off, and everybody's a goofball in first grade and kindergarten, so the kids don't stand out. They're not having any awareness that they're even having tics. The parents are more concerned about the tics than the kids are. But tics tend to peak between 10 and 12 years of age, like 5th, 6th, 7th grade, and that's partially due to the fact that kids at this age are becoming more self-aware of how others, their peers, are seeing them and are reacting to their tics. And they start getting self-conscious about their tics. They start getting embarrassed about their tics. And so what do? They try to suppress their tics. Well, that's stressful. And when you can't have tics in school because it's embarrassing, you're going to build up these tics inside. And it's very important for the families to recognize when the kids get home from school, open up that pressure cooker. Let them have the tics. Don't draw attention to the tics. Don't talk about the tics unless the kids want to talk about them. Have the teachers know, just ignore the tics. The more you point them out, the more self-conscious the kids are, the more stressful they are. They're trying to suppress them. That stress causes more tics. More stress, more tics. It's a vicious cycle. So I like to have what we call a tic safety zone at home, where nobody's asking the kid about the tics. We got to talk to the parents. We've got to talk to relatives. And who's going to talk to the relatives? Who's going to talk to the baseball coach? The parents are. So education here is really important. I want the parents to be educated so that they can advocate for their children. And if we do a good job with this, and we normalize what this looks like to the child, by the time they're an adolescent, it's not a big deal. Everybody knows that Johnny has Tourette syndrome. They want to talk to him about baseball or something else. And so Johnny doesn't have to feel self-conscious about those tics. And so we're less stressed about the tics, and guess what? They get better. And if you look at the natural history of tics, when we get into adolescence, 1/3 of kids will stop having tics for the rest of their life. Another 1/3 will have a significant improvement of tics, and another 1/3 will continue to have tics. So I'm in this for the long run with the kids and the family. I want to do a good job. I want the parents to be able to advocate for the kids when they're younger. I want the children to be able to advocate for themselves when they get older. So that's why I recommend that the children themselves read up about Tourette syndrome, kind of embrace the fact that they have Tourette syndrome. Don't be ashamed about this. Don't be embarrassed about this. And learn about how to answer what is a tic. You need an answer. What is Tourette syndrome? You need an answer because mom and dad aren't going to be there all the time for you. So with that being said, let's talk a little bit about some of these other neurocognitive and neuropsychiatric comorbid disorders associated with Tourette syndrome. And probably the one that comes up the most is ADHD, because up to 70% of children with Tourette syndrome have clinically significant ADHD. And I think it's important to recognize that, especially ADHD combined type with hyperactivity, those symptoms are going to be present before the first tics are recognized. And if that's the case, what are you going to do? You put a child on a stimulant medication for ADHD, and what happens? 6 months later, a year and a half later, they start having tics. So everybody assumes that the stimulant medications are causing the tics or are worsening the tics. And in fact, what we're going to see, and there have been some very good studies that have been looked at in a very careful, blinded, placebo-controlled crossover trials of children with Tourette syndrome and ADHD. And in fact, stimulant medications do not exacerbate tics in the vast majority of children. So I treat ADHD in kids with tics exactly the same way as I treat ADHD in children that don't have tics. And if they get a tic exacerbation, I'm not going to change the stimulant. I'm not going to try to work with non-stimulant medications that aren't as effective for the core symptoms of ADHD because I'm worried I'm going to make the tics worse. And I think if there's one thing I would like primary care pediatricians to take home, it's that message. Because so many of these kids are not managed appropriately for their ADHD symptoms. And sometimes that makes the tics worse because the kids aren't doing well in school. And sometimes you put them on a stimulant and they're succeeding in school and their tics get better. So don't be afraid of using stimulants in children with tic disorders if they have clinically significant ADHD. There's higher background rates of learning disabilities and learning differences in children. And learning disabilities can be complicated by ADHD. And for those of you that take care of kids with ADHD, you recognize they also have a lot of executive function difficulties. And that can exacerbate learning disabilities. They're disorganized, they don't have good time management, they're not prioritizing what they have to study. So working on executive function skills is very important for kids with ADHD, whether they have Tourette syndrome or not. Anxiety is probably the second most common thing I see with Tourette syndrome. And as we talked about earlier, anxiety and stress can make tics worse. And so sometimes working on the anxiety actually makes the tics better. And that may be an approach if we're not making progress with pharmacotherapy for treating tics with typical tic medicines. Sometimes I'll shift gears if it seems like this child has a lot of anxiety, and we'll treat their anxiety and see if that helps with the tics indirectly. Phobias for kids with anxiety can be exacerbated by their tics. They don't want to go out in public because they're already anxious about going out in public. And then if they have a generalized anxiety disorder, it just makes everything worse. OCD, obsessive compulsive disorder, actually is sort of rarer, but obsessive compulsive behaviors are really common in children with tics. Evening up, counting, needing to be organized. And we need to recognize that anxiety drives obsessive compulsive behaviors, and so those guys can interact with one another. The need for washing our hands and germ phobia is much less common in the OCD that we see in Tourette syndrome than the OCD we see without Tourette syndrome. Mood disorders are becoming increasingly recognized. There's an increased risk of suicidality in children with Tourette syndrome, and so this needs to be screened for as well and possibly treated. Poor self-esteem can be an issue as well. So last little bit to talk about our treatment for tics. First take-home point, most kids with Tourette syndrome don't need to be put on medicine for their tics. We need to do education, we need to have our tic-free zone, we need to advocate for them, normalize this for them. But I'd probably estimate about 20% of kids I see with Tourette syndrome I'm actually needing to use, to intervene for the tics. themselves, above and beyond education. Recognize that tics should only be treated if they're causing significant psychosocial dysfunction for the patient, not mom and dad. Like I said, I never treat kids in kindergarten, first grade, because they just don't care. They just don't stand out. So, but you know, 5th grade, 6th grade, 7th grade, high school sometimes. And we have kind of 2 approaches. We have psychopharmacotherapy and CBIT, which I'm going to come back to the pharmacotherapy in a minute. So my approach to seeing a child with Tourette syndrome is the first thing I do is we talk about their tics, and we kind of grade, you know, how severe are the tics, how disruptive are the tics. But then we're going to screen for anxiety, we're going to screen for ADHD, we're going to screen for OCD, we're going to screen for mood, etc. So I understand all the issues that are going on with the child. Then I got to rank them. What's causing the greatest degree of psychosocial dysfunction? If it's tics, we're going to treat the tics. If it's ADHD, we're going to treat the ADHD first. If it's anxiety, we're going to treat the anxiety first. And then we're going to let the dust settle. We don't want to try to co-treat 2 or 3 things at the same time. Because sometimes you treat something and something else gets worse, or sometimes you treat something and something else gets better. The Tourette Syndrome Association has a wonderful website, and I encourage parents and kids to go to that website to learn more about tics and Tourette syndrome. It's a really good resource for them. I think that it's important for people with Tourette syndrome to know that they're not alone, that there's a lot of people that have Tourette syndrome. Kids with Tourette syndrome grow up to become adults with Tourette syndrome. Adults with Tourette syndrome can do just about anything. I like to give the example of the surgeon that goes in and does an operation and doesn't have a single tic during that complicated procedure. And then he has to go to the doctor's lounge and kind of get the tics out of their system. So people are musicians, they're airline pilots, they're surgeons, they can do just about anything. The local Tourette syndrome support groups are very helpful as well for the families. And then the last thing I want to talk about really quickly is treatment of tics. There's American Academy of Neurology guidelines that came out in 2009 with different levels of evidence. And basically, education, education, education. Probably one of the most important interventions for treatment of tics is this CBIT, this comprehensive behavioral intervention for tics. And this is a habit reversal therapy where the kids learn to recognize those premonitory urges, and once they can consciously recognize that premonitory urge that occurs just before the tic is exhibited, they do a counter movement. Maybe it's circular breathing, maybe it's holding their neck down, and they hold that counter movement until that premonitory urge goes away. And you have to do this with one type of tic at a time. The advantage of this is that there's no side effects, and they can take this with them. They feel they have some control over their tics, and that's really, really important for them. It's usually about 6 or 7 weekly sessions, and then they may need to come back for 1 or 2 sessions periodically. Unfortunately, this is an intervention that is not widely available in the Austin area, and I hope that over time we can get a few more providers for this, because this should be first-line therapy for anybody that needs intervention for tics. As far as medication goes, the AAN guidelines do recommend alpha-2 agonists as first-line treatment. That's your guanfacine and your clonidine. I kind of find they're wimpy tic medicines, but they're very well tolerated, and that's, I think, why they're first-line treatment. The more effective and more potent tic medicines are neuroleptic medications. And the reason they're not first-line is because they're not as well tolerated. And if you look at evidence-based medicine, which is what these guidelines come up from, these are old studies with these medicines, and they're putting kids on 5 to 10 milligrams of Haldol a day. Well, of course they're not going to be well tolerated. So I use typical neuroleptics like flufenazine or haloperidol, or atypical neuroleptics like aripiprazole or risperidol. Little tiny dosages. We don't get into extrapyramidal side effects. The main side effect that limits dosing is sedation. And I try to build them up. Like on haloperidol, my maximum dose a day is going to be 2 milligrams. It's going to be 1 milligram twice a day. It's either going to work there or it's not going to work. And what I like doing is building them up to a dose where we have an improvement in the severity of the tics without causing side effects, but not necessarily stop all the tics. And then when they're doing well, I try to gradually take them off. And then if we have a bad tic exacerbation, bam, we can go right back on. So coming on and off low-dose neuroleptics is what I like to do for most of these kids, because if they're already on 2 milligrams of haloperidol a day and they have a tic exacerbation, you're stuck. So it's always better to go off and on. Kids that have really, really difficult to manage tics are very difficult to treat. Kids that have mild tics don't need treatment at all. So it's these ones in the middle that you can probably make the best difference with. And I think with that, I'll stop and see if there are any questions. Oh, thank you. We have a question up front here.
Great talk, Dr. Deputy. I had a question about distinguishing functional tics, which you started to touch on, versus physiologic tics, because I really struggle with telling the difference.
Yeah, so they're called TikTok tics, right? Because TikTok is a social media app where there have been several adolescents, usually, that are portraying their Tourette syndrome and filming it for the benefit of the world, so that we all have a better understanding about what Tourette syndrome is. So functional tic disorders, as I mentioned, are explosive in onset and are usually composed of a variety of complex motor and complex focal tics, directed behavior, self-injurious behavior. Coprolalia is really common in this group. And abrupt onset. And yes, you can see all these things in chronic tic disorders, but you want to go back. Did you have those simple tics? Did you have eye blinking or facial grimacing or head jerking or sniffing tics or throat clearing tics that over years have gradually evolved into these dramatic, multiple complex motor and vocal tics? That's Tourette syndrome, not no tics, and then all of a sudden, bam, we're having these complex tics. So that's the main thing that I use, but it's phenomenology. And there are some new articles coming out in the literature about the phenomenology that can differentiate the two. Okay, thanks. Yes?
I wanted to ask a quick follow-up to that. We've been seeing a number of patients who get sent to the ER for especially these rapid onset complex tics that become quite disabling, especially with the rapidity of onset. What advice do you have for the sort of short-term immediate management of these patients?
Yeah, I think if you're really stuck and it's really bad, benzodiazepines, a little bit of clonazepam to maybe take some of the anxiety down, because it's usually anxiety that's driving a lot of the tics. Okay. I'd like to bring up one more thing too. PANDAS is this disorder, psychiatric autoimmune neurological disorder associated with strep. Is very controversial, and my preference would be that we not check ASO titers in somebody that comes in with new onset tics, because that's going to create a big maelstrom. You can take that or leave it, but I'm not a big fan of PANDAS. Yeah, I think we have a question in the back. Yes, ma'am.
Yes, I have some follow-up to the anxiety tics, and sometimes these kids are progressing to like almost to pseudo-seizures and a lot of just somatization, and I wondered what your experience with that relationship is, and what the utilization of early on when you first see the tics associated with anxiety, like treating with like an SSRI or something, trying to manage the anxiety before they get to the point of the pseudo-seizures.
Well, anxiety itself is different from conversion disorder, which is a non-epileptic seizure, but they can go hand in hand, obviously. But I will use SSRI as a first-line therapy as I'm going through my tic prioritization. Or do we have a lot of anxiety? Are anxieties driving tics? I'd rather use an SSRI there, actually, than to put them on a neuroleptic medication, because I might kill two birds with one stone. So I think that we should think about anxiety, and I think we should treat anxiety, and I think it's a priority if it's there. It's those kids that just have tics or have predominantly tics that are disabling, that don't have a lot of anxiety. Those are the ones that I'm going to be using neuroleptics for as first-line treatment, if that answers your question.
So you don't really find that there's a relationship between tics and conversion disorder?
I do not. They are separate issues. Just like anxiety and conversion disorder are separate issues. Not everybody with conversion disorder has anxiety, but the rate of anxiety is higher, but they're not causal. They're just an association. Those functional tic disorders have a lot of anxiety with them. They're almost like a conversion disorder, but oftentimes they have anxiety, but not always. So it's just kind of a new phenomenology, and that's the goal of the psychologist, is to do the cognitive behavioral therapy for anybody with conversion disorder, but they also need to screen for anxiety, and if there's anxiety or mood disorders, those need to be treated separately. Yep, thanks. Yes, sir.
So, comment on the use of nicotine patch for tics.
All right, so there's a lot of medications and interventions that have been touted as being useful for tics. You can read about just about any medication makes tics better or makes tics worse, and part of that problem is we're dealing with something that waxes and wanes and fluctuates. There were some studies that supported the fact that nicotine might be helpful for tic severity, and there was just a lot of problems with using that intervention because of the potential long-term addiction. So it's pretty much fallen to the wayside at this point.
Dr. Deputy, we have a question on the chat.
Okay.
Let's see, hold on, just move down. So Dr. Patil asks, so what is the best way to control tics when on stimulant meds? Just reassurance? Guanfacine?
Yeah, so that's a very good question. So let's say we're on a stimulant medicine and we know we have tics, and the tics go through their exacerbations. Change your stimulant medication only if you need to change it to treat the symptoms of the ADHD. Don't change it because there's a fluctuation with tics. Ride through the tic fluctuations with the same dose of the stimulant medication, and reassure the parents if they do perceive an increase in tics after starting the stimulant, that if they go for a long enough period of time and they look back, they're going to see overall there's not an overall increase.
Also, Dr. Friedman is our fellow colleague and expert in psychogenic non-epileptic seizures. He commented, he agreed that functional tics have more in common with PNES than physiologic tics.
Yes, absolutely. They're kind of like a conversion disorder. Absolutely.
What's the value of the Yale,
Global Tic Severity Score. So the question is, what's the value of the Yale Global Tic Severity Score? It's very useful for studies. It's kind of a more involved battery to go through in the office. I think the easier thing to do is a Likert scale for the severity of the tics in the office, as long as you're not doing a study or an intervention. But the value of the Yale Global Tic Severity Scale is that it not only quantifies the tics, it also looks at the functional impact of those tics on the children. So that's a useful scale, and it is pretty much the standardized scale when you're doing any kind of intervention for tics if you want to study the outcome. No, not really. I think I just kind of look at the kid. Have we gone through our education? Is there anything more we need to do there? No. Are you really having a hard time with this? Yes. A lot of times these kids will be ticking right in front of you in the office while you're examining them. They look uncomfortable. It's pretty easy to tell, I think, for the most part. Yeah, you need intervention. You just need education. Okay. Okay, thank you.
Thank you so much, Dr. Deputy. We're going to take about a 5-minute break, so everyone will be back at 10:20. All right, welcome back. So next up we have Dr. Sarah Weatherspoon. She trained at Cincinnati Children's and has joined us by way of Memphis. And she'll be talking to us about infantile spasms. Thank you.
So I want to talk with you today about infantile spasms, both from the broad perspective that I would want, whether general neurology, general pediatrics, or epileptology, things to understand at different levels. It's a diagnosis you don't want to miss. And so we'll be going through some of the natural history. Did I do this correct? Yes, okay, thank you. So I do a little bit of work with neurologists who make Valtoco, but nothing relevant to this talk. Objectives of this study, to review the natural history, workup and treatment of infantile spasms, and to understand the importance of rapid access to infantile spasms diagnosis and treatment using a multidisciplinary center as a means of bridging the gap from patient to an effective provider. And we'll talk about what does an effective provider mean. So just a couple of cases that are, I'm sure, familiar to many of us, how these patients may cross our paths. So this is a little story of a girl that I saw several years ago who had been a 28-week preemie, but no major neurologic complications in the NICU, mainly respiratory, did quite well. She began to have some events where her arms would come in and flex and her eyes would do a funny little roll upwards, lasting about a second each, occurring in clusters that her mom noticed. And her mom was a nurse and realized that this was something that seemed out of the ordinary, brought it to her pediatrician's attention, who not unwisely said, let's watch this for a week. And if it keeps going on for a week, then I'll go and send you to neurology to get this further investigated. But the mother said, okay, well, we'll see, but her anxiety was growing. So she got on the internet, she looked at some YouTube videos, which as much as we know that the internet can be a dangerous thing, sometimes, especially as it comes to spasms, I found it actually be a helpful thing of getting parents to a diagnosis for spasms. And so the mother saw some of videos of very similar events of what her daughter was doing, and said, now I'm really worried because these are spasms and I recognize this as a seizure. And with her own medical background in nursing, she really pushed the envelope to get into neurology very quickly, rather than waiting the full week, letting just after a couple of days, she was in our clinic. We got an EEG, it was diagnostic. We came up with a diagnosis of spasms for her daughter and started her on treatment. She's actually done really beautifully. And they sent me an email just this week of, she's now 5 years old and just amazing, seizure-free, doing wonderfully, being a good big sister. So this is a typical story, and this is a video. It's part of a repository so this is not my patient, but this is exemplary of what these events look like. Can you help me start it, or I just click it? Okay. So this is a little baby where she was brought in for similar types of episodes that were paroxysmal and brief, and she would pause like you see right here, and then she goes back to crying in between. The crying is when she's normal. The pauses are actually the spasms, and sometimes they're very subtle. It may just be a brief pause, a brief eye roll, a brief stiffening of her arms, and they last just 1 second. They would be easy to miss if they only happened once, but usually these are happening numerous times a day, so they start to garner attention. Here she goes, a much more dramatic one. And sometimes you see this crescendo effect where the cluster itself will start off very mild, and then as it progresses over the next few minutes, becomes much more dramatic and involved. And sometimes babies will become very fussy between spasms or after a cluster's over. So these are some of the 4 key features to know about spasms and to recognize them is, first of all, this flexor extensor semiology. So it may be flexion at the elbows, it may be extension outwards. Sometimes it's a subtle head drop, sometimes it's a dramatic head drop. It depends on how much motor control that infant has. If they're already hypotonic at baseline, it can be hard to see any head drops or neck flexion. Sometimes it's much more subtle, just a jaw opening or an eye opening or an eye roll, although I tend to see that more in pre-treated infants or as, again, at the beginning of a spasm cluster when it's starting off in that more subtle phase. They tend to cluster, so this means that the spasm itself is just about 1 second long, but it will occur for that 1 second. A few seconds will go by of relative normalcy, the spasm happens again, et cetera, off on, multiple times, usually for anywhere from 3 to 10 minutes. Again, the duration of the seizure itself is seconds. So this is very different than status epilepticus or a focal seizure going on for 2 or 3 minutes. The seizure itself doesn't require intervention in that moment. Typically, they don't stop breathing. There's not usually dramatic vital sign changes that are dangerous. The seizure is very, very short, but it is very, very dangerous, as we'll discuss. And we tend to see these mainly during sleep-wake transitions, or they'll occur most prominently during that time. So soon upon awakening, within about 30 minutes, the parents will note that they start to have this cluster. They also are often missing clusters, understandably, because, as we know, infants like to wake up at night. And sometimes you don't see this, but they may do it at 2 a.m. when they're waking up during an arousal period. We tend to see that when they come in and get hooked up to video EEG. So there are a lot of things that can mimic spasms, and this is one thing that I think leads to sometimes a delay in diagnosis, is these benign things, these normal baby movements sometimes, like a moral reflex, are much more common than spasms. And so surely when these children are coming through just a regular appointment, it's understandable that most likely the benign things are going to be at the top of a provider's mind. Things like benign infantile myoclonus, benign sleep myoclonus, and I think this is very critical. So spasms tend to occur during wakefulness, sleep myoclonus occurs during sleep. Sandifer syndrome is something we've heard a lot about, especially in general pediatrics. This is essentially really significant reflux that is associated with some back arching and posturing that can be paroxysmal. I've had patients, one patient with tuberous sclerosis who actually went through the GI clinic first for bad reflux in these events, and the GI nurse practitioner called her neurology nurse practitioner friend and said, I don't think this is reflux, I think this could be seizure, and sent them to our clinic, ended up getting the diagnosis of spasms and eventually tuberous sclerosis as the underlying cause. Breath holding spells, so there can be a lot of posturing and stiffening with these events, but should be preceded by crying or a knock on the head or some sort of thing that makes them upset typically. And then there can be other seizures that can look like spasms, and these are best distinguished on the EEG or visually, but things like myoclonic seizures, which is more of a brief lightning bolt twitch that may not have the same EEG features necessarily as spasms do. So this is what a normal baby infant EEG looks like, right? A lot of us recognize this, or if you're not familiar with looking at EEGs, it's a nice, smooth, squiggly pattern. Each line on here represents essentially 2 electrodes, and so each line has its own space. It's not touching the other lines. We call this normal amplitude. It's not really tall. Nice, smooth, squiggly looks. This is what we call hypsarrhythmia. So hypsarrhythmia is a term derived from the Greek for mountainous or chaotic and lack of rhythm. So that mountainous feature is how high these brain waves are, usually greater than 200 to 300 microvolts. And so as we tend to say in neurology, the lines touch each other. If you turn it upside down, it looks the same as if you turn it right side up. There's not really a good organization. It's chaotic. There's lots of spikiness to it, lots of big slow waves. Sometimes there are periods of electrodecrement where it's relatively flat in between. That is also abnormal. So this is the pattern that we're looking for in a child who may have spasms. However, about 18 to 25% of children with spasms will not produce this pattern, but still have spasms. So they may just have an abnormal EEG. Maybe they have some spikes. Maybe it doesn't look so bad. Maybe it's a little on the slow side, but it doesn't really meet all the criteria for hypsarrhythmia. That doesn't mean they don't have spasms. And in my experience, this tends to occur most in children who have underlying brain insults, children who've had significant HIE, hypoxic ischemic encephalopathy. Maybe they had intraventricular bleeds as a premature neonate. These children don't always produce a really classic hypsarrhythmia pattern, and therefore are often overlooked because they may also have some funny movements. They are already having some developmental delay, so you may not get that good story of regression that we associate with spasms. So those are babies that I worry about, frankly, the most of the diagnosis being missed, because this pattern on EEG of hypsarrhythmia is pretty clear cut when we see it. And again, this is the interictal pattern. This isn't what they're doing when they have a seizure. This is what they're doing when they're not having a seizure. We see it most prominently during sleep, so it's very important to get sleep on our EEG recording if we're concerned about spasms. And what we think is that this is disrupting normal brain development. So we know if we don't get spasms treated, that child may go on to have significant developmental delay. We're going to come to some of those prognostic sorts of things a little bit later. But what we think is going on is almost like a status epilepticus pattern, that there is an abnormal pattern disrupting normal myelination and brain development that, if it is not corrected, will cause long-lasting neurologic problems. So this leads us into the idea of an epileptic encephalopathy. So it's not just the seizures themselves. Again, spasms are 1 second long. They don't cause vital sign disruption. We don't need to urgently treat them with Versed infusions or propofol infusions. However, they represent an underlying process that is very disruptive to normal brain function, and if not addressed, will cause neurologic decline. Sometimes I'll liken it to, like as I'm talking with a family, that the spasm is like a fever. The fever alerts you that there's an underlying infection that you want to go after and identify and potentially treat. If a child comes with a fever, you're going to look in their ears, you're going to listen to your lungs, you're going to think about pneumonia, ear infections, viral infections. You're going to treat those if possible. Similarly, the spasm seizure itself isn't so awful, doesn't cause damage in and of itself. It is a red flag that something is going on underneath that needs to be addressed. So our treatment goals are both to make the spasms, the seizures, stop, but also to improve the EEG. You don't always get rid of it or make it, totally normal, but you want to look for improvement. One of the things that's important in figuring out about spasms is what is causing it, because there are numerous etiologies. About 60% will have an identified etiology that are either a structural, like a hemimegalencephaly, genetic, like an STX-BP1 or trisomy 21 is very common, infectious, like HSV meningitis in the neonatal period, or metabolic, like a pyridoxine-dependent epilepsy. But 40% will fall into this unknown category. It doesn't mean that there's not something there, it just means it's not the level of our understanding. And in terms of workup, we're going to usually want to get a brain MRI to look for one of those structural causes or something that points us to a definitive diagnosis like tuberous sclerosis. We want to get some genetic testing. We'll often send these epilepsy gene panels, and then I send them on to my colleague, Dr. Ulick, for more in-depth testing if I haven't come up with anything. Metabolic studies are not very high yield, but they have a role and a time and a place. So let's talk about treatment a little bit. We have two main categories of treatment. The first is what we call hormonal therapy, which we'll refer to as ACTH, or prednisolone is what we tend to use. So this was first described in 1958, or first published in 1958 by Gibbs and Gibbs in Belgium, where they used ACTH to treat children with infantile spasms, or what they called the hypsarrhythmia of Gibbs at that time. And what they found was a dramatic response. Now, they used it a little bit differently. Sometimes they used it for up to a year, and as you and I know, we tend to treat for 2 weeks at a high dose and then wean. But what they found was this was really effective. So this has become a mainstay of treatment. In the United States, it's in the form of Acthar, which is considered natural, meaning it's derived from the pig pituitary gland. In the United Kingdom, they use tetracassactide, which is a synthetic form. So when we look at studies, you'll see both mentioned. We often in other institutions, we use prednisolone because it's readily available, relatively non-invasive. We all know that these hormonal therapies will come with potential side effects. Most commonly, I see irritability, quite significant. I tell families that their child's going to sleep like a newborn. They're not going to sleep well anymore. They need extra hands to help them care for that child during that time. They may be hungrier and want to eat more. Rarely, they may see some blood pressure spikes, so we tend to have them monitor that when on the high-dose regimen. But we don't really see the elevated glucose. I don't check those sorts of things because it is a short-term treatment. So we do 2 weeks at a high dose, and then we wean off. And at the 2-week point, we really should know, did it work or did it not? The second treatment that is effective in about 50% of patients is going to be vigabatrin. This is an oral medication. It enhances or it increases GABA in the synaptic cleft. However, that's probably not its mechanism for treating spasms, because there are other things that are GABAergic, are benzodiazepines that don't treat spasms. So there are probably some downstream effects that we don't completely understand at this time about why vigabatrin is so effective for spasms, particularly if there is in the setting of tuberous sclerosis, or that also means if there's an underlying dysplasia of the cortex, this can be particularly effective. We know that there's some potential side effects of vigabatrin. The most common that I will warn families about, of course, are drowsiness, low tone, being somewhat zoned out. Those are common side effects. Uncommon side effects include this permanent peripheral retinal injury that is irreversible, extremely rare, not really seen as much in pediatrics, more so in adults, does not affect their central vision, so it does not cause blindness, which is a misunderstanding that's out there. However, we do so, of course, warn families about them, have to sign special paperwork saying that we discuss this. And then another potential thing that we rarely see are MRI changes. These diffusion restriction, especially in deep gray matter, that often is asymptomatic. I see it a lot in the TS population because they're going for annual MRIs anyways, and lo and behold, it's on there because they're on their MRI because they're also on vigabatrin, but they have no symptoms. However, it is rarely associated with dyskinesias and sometimes some significant vital sign changes. Other treatments include ketogenic diet or epilepsy surgery. If we know there's a lesion like a dysplasia we can go after, then removing that can be curative. And then I want to talk a little bit about diagnosis and prognosis. So this case for me really highlighted the importance of making the diagnosis early. This was a baby I took care of who was born full term but had hypoxic ischemic encephalopathy, and he was in the NICU for quite some time. He was placed into the care of a foster care mother who really watched him carefully and started to notice at 8 months of age he had been making some developmental progress despite the HIE. However, started to have some regression, stagnation of his development, and these events that were spasms. These were misdiagnosed at another institution as some other kind of seizure, and he was treated with levetiracetam. Was not effective. Mom was told specifically, these are not spasms. You're worried about the wrong thing. After a period of a few months, she came to, I happened to see her in clinic. He had hips arrhythmia on EEG, he had spasms, we started treatment, but at that point, several months had gone by, and the developmental regression he'd experienced at the onset was permanent at that point. So we know that longer lag time to treatment leads to worse developmental outcomes. So the time from when the spasms start to when they get to, quote, an effective provider, meaning a doctor who starts or a provider, any provider who starts a treatment that is either a hormonal treatment and or vigabatrin. And I highlighted in red these Vineland scores, which are a assessment of development that they looked at in children, and they compared that to the lead time to treatment. How long did it take them to get put on treatment? There was a drop in a standard deviation of their cognitive scores if the treatment delay was beyond 1 week. So you think about the time to get into a pediatric neurologist can be a month. These children should not wait a month. It should be treated as a emergent, if not urgent, issue. This was a really nice study done by Dr. Hussein, who does a lot of work with infantile spasms, where he said, okay, what were the causes? And he surveyed families to say, how long did it take to get to that effective provider and what were the causes? And what he found was the median time from spasm onset to effective provider was over 3 weeks. And I just told you a delay of a week can lead to a shift in standard deviation of dropping. It's not quite IQ for Vineland scores, but it's dropping your cognitive development. And almost a third of patients, only a third of patients were evaluated within that first week. We know that the prognosis is dim. If you have infantile spasms, especially if they don't respond or don't get treated, 80% of children will go on to have intellectual disability. 15 to 50% will evolve into Lennox-Gastaut syndrome. In having an infantile spasms clinic, I also have an LGS clinic. So these children have intractable epilepsy that's very difficult to treat, requiring lots of medications and other sorts of treatments. 15% of children with spasms will die prior to the age of 11, and it's highly comorbid with autism spectrum disorder and cerebral palsy. So when treating these children, I find it's really important to come at it with a multidisciplinary approach. It's not just the child neurologist. It's a speech pathologist to assess for dysphagia. There was a baby I'm taking care of just recently who's having ongoing viral respiratory infections, multiple admissions, and in the end he has such significant dysphagia that he's no longer safe to eat by mouth. We were glad to discover that so we can really enhance his overall quality of life by feeding him safely. The neuroradiologist looking for those focal lesions, the geneticist interpreting some of these genetic diseases, making sure we're not missing anything. The neuro-ophthalmologist to help track the response or potential side effects to vigabatrin over time, and more importantly, to look for cortical vision impairment, which a lot of these children have. And then our EEG technologist, nurse coordinator, our neuropsychologist, and tracking their development, and nutritionists to make sure these children are growing and optimizing their health. All of these people are very important, but at the center of it all, of course, is the patient and their family. So In summary, spasms can mimic normal baby movements, but the EEG is a non-invasive and inexpensive way to determine the diagnosis. As I often say, why would you not order an EEG? If you're in a city this size and you have access to refer a patient in for an EEG, there's not a reason not to. They don't have to be sedated. It doesn't harm them in any way. Early and aggressive treatment leads to improved developmental and epilepsy outcomes in spasms. And finally, a multidisciplinary approach to spasms improves access to appropriate treatment and holistic care for children with IS. Thank you.
Thank you, Dr. Weatherspoon, for your talk. What factors do you determine or do you use in determining whether you're going to start a child on high-dose oral prednisolone or ACTH or vigabatrin, perhaps apart from whether or not they have tuberous sclerosis?
That's a great question, and one of the slides I cut out, but so there is data that suggests using dual therapy, meaning a hormonal therapy combined with vigabatrin, may enhance spasm response and perhaps developmental outcome in the long run. So I tend to use dual therapy, except in certain cases. If it's tuberous sclerosis, new onset hasn't been discovered before, I'll start with vigabatrin. We know that children with trisomy 21 do not seem to respond well to vigabatrin and tend to have more side effects, so I don't do it there. Some of the data out of that national multi-center trial of dual therapy said children with perinatal stroke actually seem to respond better to dual therapy. So I think some of the data is a bit muddy on that, but because my personal philosophy of treatment is the potential outcome is so dismal and severe that we need to be aggressive up front with the treatments that we have, because beyond these two things, nothing else really is quite as effective.
And perhaps a follow-up to that would be, did the use of high-dose oral prednisolone come about because of the exorbitant costs of ACTH and difficulty in access and delay in initiation of treatment, or is there some benefit even if those factors weren't considered?
I think that intramuscular injections are hard to give. So especially if I'm taking care of a child who's having a late onset of spasms, like a 2-year-old, I can't imagine trying to strap a 2-year-old down twice a day to give them a shot like you would a vaccine for several weeks. So I think there's certainly even places where you think, well, I would definitely choose oral. I think oral is very effective. I think it's much more accessible. I think the expense is really a United States problem and not an international problem. So I think there's also kind of a mental decision we have about, and this can even be a bigger issue about vaccines and shots and pain and discomfort versus giving something orally. I do see more, it seems like, and just speaking from personal experience, not data-based, that I see a little bit more secondary adrenal insufficiency from prednisolone. Because of the difference of where it's targeting on the HPA axis. So it's something that I'm more mindful of since coming here and using more oral prednisolone than my prior institution where I use more ACTH.
A couple of quick follow-up questions. One, I was wondering if you could comment on the typical timing of developmental regression and onset of spasms. I know those two are often associated, and I have heard it argued, well, this must not be spasms because their development is normal. And what is your experience with the typical relationship and timing of those things?
They seem to come together, but when spasms start, the typical experience of a family that they share is that they saw it one day, they didn't see it for a couple of days. Then they saw it for a couple of days, then it's maybe skipped a day, but then it really became daily. And as they look back, then they start to say, and that's when I noticed something different about my child's development. And you're right, you don't have to have developmental regression. That's where you have West syndrome versus infantile spasms. If we were to really get nitpicky, the syndrome, that triad, one of those is developmental regression. But a more subtle thing that I always tend to ask families, just from my own learning, is did your child stop smiling? And that's very common. So you don't necessarily think about, I mean, that is a developmental milestone, is a social smile, but it's not like you stop crawling or stop to this, but they stop smiling. It's a little bit more subtle, but a lot of families will endorse that. And I think we had a question back there.
so I don't know if I even really need this. Like, I usually can get everyone's attention without it. So you kind of hinted at this, but are there children that have normal neurodevelopmental outcomes when they're diagnosed with infantile spasms? I mean, when I was in training, basically this was like basically a developmental death sentence that, that the child probably, especially when we didn't find any, genetic or anything on the scans or things like that.
So that's always tough to answer because the kids who do well never come back to neurology clinic. But I do actually discharge people from neurology clinic because that child is 2-3 years out, normal developmental spasm free. And I remember talking with our residents before about this, and then like same kind of perception because they see all the worst cases. And I'm very fortunate on the seeing these patients on the outpatient side. I see some of the really good outcomes too. So there are children who do well, and as you just pointed out, it sometimes not having an etiology can be bad. Sometimes it can be good. However, so sometimes even though we get the spasms to stop, doesn't mean that child's going to do well developmentally because it's more dependent on their underlying etiology. So if they have one of these significant genetic diseases like that STXBP1, I hope I said that right, that I mentioned earlier, those children, that gene alone is going to cause significant developmental issues no matter what the spasm response is.
All right, thank you, Dr. Witherspoon. So next I'm going to introduce Dr. Elizabeth Tyler Cabara, and she is our Chief of Pediatric Neurosurgery here at Dell Children's, and she will be talking to us about disorders of head shape and size.
Thank you very much. All right, I'm going to also try to juggle two things at once. I can't do anything simple, so I have to make this interesting. And so the title of this talk is Big Head Todd and the Monsters. This will date me because I will confess that I first saw them in concert before anybody else knew who they were. But I always think this is kind of a humorous way to talk about large heads and funny shaped heads, just to try and keep the mood light. Disclosures, I have no relevant financial disclosures, and we will not be discussing any off-label presentations. So what are the frequent neurosurgery referrals? Big heads, increasing head circumferences, funny shaped heads, small heads, concerns for increased ICP, and perhaps this covers a variety of different problems that may or may not be related to increased ICP. So fussiness or vomiting, developmental delay, and then one that probably is almost always related to increased ICP is sunsetting eyes. And these become sort of the bread and butter of a large part of the referrals that we will see as new referrals in the neurosurgery clinic. So we're thinking a little bit about what are the causes of hydrocephalus. So when these large-headed kids have hydrocephalus, is it aqueductal stenosis or some other structural abnormality? Is it post-hemorrhagic? Is there a history of prematurity and has the child spent time in the NICU? Is it post-traumatic? We certainly see many of these kids. Many of them are identified while they're still in the hospital, but we do see delayed presentations. Post-infectious, the kids who have had group B strep meningitis in the hospital but managed to escape without hydrocephalus still need follow-up because some of those kids will develop delayed hydrocephalus. One we don't see very often but I have taken care of is post-TB. Spina bifida, of course, is a cause, and now with the number of kids who are being closed in utero, where there's a great deal of investment of not having hydrocephalus, we sometimes see these kids actually present quite symptomatic. And of course, we have our genetic presentations. Many of those are diagnosed in utero now. And then last but not least is certainly our patients who are presenting with hydrocephalus because of obstruction from a tumor. All right, so we will keep moving forward with these referrals. And I'm going backwards, so we'll go back to going forward. This is what happens when I try to do things with more than one hand, when I'm not staring under the microscope. So here's an interesting example of a patient who was referred. And so if I can make the, wow, I bet I can't do this. So you can see the red squares represent what the head circumference looks like it's done, but the blue dots actually show what the age-corrected head looks like, which is slightly, I don't know if that's less scary or more scary. And then here we can see another example of a child who has started way below the curve and has now tracked onto the curve, but in fact has this head CT. And so we have to take not just the trajectory of the head circumference into consideration, we have to take into consideration age correction and also the physical exam. And so in this case, obviously, we have fairly large ventricles. We can see that there is some changes periventricular, and so that becomes concerning for hydrocephalus and requiring treatment. Well, what do we do to treat these children with hydrocephalus? And this is something that hasn't changed a whole lot in many ways. So in the 1950s, we came up with ways to do CSF diversion with ventricular peritoneal shunts or ventricular atrial shunts. And so we have a catheter that gets placed into the ventricles. It runs underneath the skin and then terminates into some space which will absorb fluid. The bladder is a bad place to put it because then you pee out all of that fluid and you end up with electrolyte imbalances. So you want it someplace where you're going to be able to recollect that fluid. The abdomen is our first choice, but we sometimes go to the atrium. We sometimes go to the pleural space. We do crazier things. We sometimes go to the superior sagittal sinus or the gallbladder. We can get very creative if we need to. But there are complications associated with shunting, and so one of the other techniques that has been used is the third ventriculostomy. These are just sort of some of the images of what you would see. So when you're looking into the ventricles, you see the choroid plexus coming down to the foramen of Monro. And when you pass the camera through the foramen of Monro, you can see the mammillary bodies. You can see up here is the infundibulum and the anterior commissure, and then here, where that dot is where we want to come through the floor of the third ventricle, and then you can see these openings through the floor of the ventricle and through the membrane of Lilliquist over this. The idea here is, if you think simplistically, is essentially it's changing the plumbing, but the other part of this is that CSF is almost certainly not a passive system. It is almost certainly gated, and some people believe that the third ventriculostomy actually restores the cardiac gating by transmitting the pulsations of the basilar artery back up into the ventricles in order to help regulate CSF production. The jury is still out because we still don't really understand hydrocephalus well enough to answer that question. We know that in young children, that just doing an ETV typically is not sufficient. It will often scar back over, or it is not. It doesn't really serve the purpose of completely eliminating the hydrocephalus. And so, what has been added to that is choroid plexus coagulation. This turns out to be very successful in post-hemorrhagic, post-infectious and spina bifida patients who were traditionally thought of patients who were not good candidates for third ventriculostomy. But what about the big-headed kid who has benign macrocephaly? This comes in with all sorts of different names, some of which don't sound very benign. Subdural collections of infancy, I don't know. If you say that to the care team, they think that you're talking about a child who's had child abuse. Subdural effusions. Benign extraaxial collections of infancy is a pretty common one. Benign enlargements of the subarachnic spaces. Bessie, the first time someone said Bessie to me, I looked at them like they were crazy. Hypodense extracerebral fluid collections, and the list, as you can see, goes on. So what do these patients look like? Well, they often will have fairly rapid crossing of the percentages in very early. And if you get imaging on these kids, what you see is they in fact have enlarged extraaxial spaces where the density is the same as the CSF within the ventricles. And so the way I explain that to patients is often that the box grew before the brain grew. And so what we will often see with these kids is that, and here's another good example where we've done an MRI, and you can actually see here that this is in fact subarachnoid spaces that are enlarged, because you can see the bridging vessels coming through the subarachnoid space, and in fact the subdural spaces are quite small. These kids will eventually begin to plateau out and track back towards the curve. The other thing is oftentimes there is a fairly strong history of big heads, and one of the things we always look at is how big are mom and dad's heads, because what you will see, particularly in this example, is dad's head was way above the 95th percentile, and mom's head was really sitting right at about the 95th percentile. So we can easily say to the pediatrician, we anticipate that these kids are going to hang out above the 95th percentile, and that is an acceptable place for them. All right. And so here we've again, example of them tracking back. So when we are looking at a kid with a big head in the clinic, we are looking at how rapidly or how many percentage lines have they crossed, and are they disproportionate to their parents? If they're truly disproportionate, that is when we will consider obtaining imaging, or if that rise has been really out of proportion to what we would expect with the benign macrocephaly. If it's normal, then we're pretty much done, unless there's concerns for increased ICP, in which case we'll continue to follow. If the imaging is abnormal, then those patients get referred to neurosurgery. There you go. All right. So with the treatment of the benign macrocephaly, really we do not do much in the way of significant treatment other than watching. If we become really concerned, we can do an LP or ICP monitoring to determine whether or not they have increased pressure. And if they do, then we can move towards ICP, some kind of diversion. This is in the difference here would be the non-accidental traumas, and in these cases you can see that now instead of, we clearly have both the subarachnoid fluid spaces and the subdural fluid spaces, and the majority of these patients will go on to need to be treated. I think one way of trying to sort of differentiate these two when you are seeing these patients is the benign macrocephaly is often going to have a soft fontanelle. They're not going to have distended scalp veins. Their sutures are going to be normal. Whereas in the hydrocephalus kids, you're often going to see a tense or fuller bulging fontanelle, the distended scalp veins, and displayed sutures. So the other common referrals to neurosurgery are our patients who come in with funny shaped heads. And this is just a brief slide to show you and remind you about the sutures that are in place that help the skull accommodate that rapid growth in the first 2 years of life. Probably the most common one we see is metopic synostosis, and so these kids have a early fusion of the metopic suture, or down the middle of the forehead, and you can see that what they can get is this very triangular shaped head. Many of these kids don't need treatment, but the ones that have profoundly trigonocephalic heads, like this one here, with real pinching across the temporal lobe, temporal region, may in fact benefit from treatment and referral to the craniofacial clinic. Sagittal synostosis comes as a single suture fusion, and that is the middle suture, and that in order to accommodate that, you get growth of the head front and back, producing the dolichocephalic, or the long skinny head. These kids now are typically referred for surgery. One of the ones that we see actually have seen quite a bit of recently is the coronal synostosis. So when you have a single coronal suture that is fused, you end up with the raised eye. It is usually quite noticeable, and usually the parents notice this really right at birth. If in fact you end up with both of those sutures fused, you will just get a very short, high head. Once we start talking about more than one suture fused, we do start worrying about increased ICP and some urgency to treating those children. Lamboidal synostosis is probably right now one of the ones that is most difficult for people to identify because it can look a lot like plagiocephaly. But in the lamboidal synostosis, the contralateral ear comes forward as opposed to the ipsilateral ear. And it is contralateral frontal bossing, which is similar to what you see with plagiocephaly. So it's really looking at what happens to the ears. These look more like a rhomboid, whereas the positional plagiocephaly look more like a parallelogram where everything is just shifted together. We also see a fair number of syndromic cases. Oftentimes there are family members who have had this. These are genetic and have typically multi-sutural abnormalities and often have other abnormalities associated with them, whether they are with the hands or developmental delay, and some of them are also associated with hydrocephalus. So as I mentioned, a lot of the metopic synostosis can be actually just observed. For many of these, if we can identify children in the first 3 months of life, they are a candidate for springs as opposed to extensive surgery. The springs, this is a great example of what this looks like. Some people leave the strip, some people don't. We get rapid expansion from those. When we have to do a larger surgery, as you can see here, it often includes removing a chunk of the skull, then doing remodeling of the skull in order to try and achieve space so that we don't have problems with increased ICP, and to achieve a better cosmetic effect. Positional plagiocephaly has become epidemic as a result of the Back to Sleep program. It is also often associated with torticollis because kids will tend to lay on one side of their head. Most of these kids will improve simply with repositioning and tummy time, but some of them will need a different interventions. This is characterized that the lamboid suture is in fact open and the ipsilateral ear comes forward. So you really see, like I said, that parallelogram shape. So besides the tummy time and PT for torticollis, we recommend lots of repositioning. If it is inadequate, we can recommend a helmet. Typically, in order to have that approval, we need to have frontal bossing and ear abnormalities. And these are some of the typical types of helmets that are available that do require that it may not be covered by insurance, and it requires 23-hour-a-day wearing and frequent visits. Again, some of the differentiations between these two are normal ICP versus increased ICP, and the likelihood that it can be treated with just conservative measures versus requiring some sort of surgical correction. Thank you, and I think I have a few minutes to take some questions. Yes, Dr. Deputy.
So there is a natural history of improvement of head shape with positional plagiocephaly. As the brain grows, it pushes on the skull bones. What is the evidence, or is there evidence, that the skull molding helmets will improve the shape of the head over the natural history?
So that's a great question. So in Canada, it is actually nationally no longer recommended to do molding helmets, and I think that's actually now made it into the pediatric literature in Canada. It actually turns out that there have been done some controlled studies that have been done looking at kids who have had molding helmets and those who haven't at age 10, and looking at their cephalic indices. And in fact, there's very little difference. And so there are definitely some people who really are proponents of not using molding helmets. The use of them in mild plagiocephaly, I think almost everybody is in agreement that that doesn't make sense anymore. In the kids who have significant facial asymmetry, although that will likely balance out for the most part over time, because of some of the social concerns, that has been one of the reasons why people have still advocated using the molding helmets to try to improve that that facial symmetry for social reasons. But I frequently will counsel families that, you know, as long as we continue to do these things, we will continue to see improvement 6 months out, 9 months out, 15 months out. And so there is definitely some disparity, and you will find the practices for molding helmets differ vastly depending on where you are and how aggressively the companies that provide molding helmets advertise. You had a question in the back.
Yes, so for mild to moderate plagiocephaly, where the family's having trouble doing the tummy time and repositioning, and it's just really taking the child a while to get better, have you had any experience with those tortles that you can get over the internet? It's like the little caps that have like a, you know, where, especially when it's like more on one side than the other.
So I'm gonna be really, so one, the tortles, I think that's really marketing. I don't know that we've seen anything. So I am, you know, I'm a mom who had a kid with a full head of hair, and I'm the only one besides the plastic surgeon, who is a good friend of mine, who knew she had plagiocephaly. And once we figured that out, you know, I'm a living proof of what you can do with repositioning if you're crazy. My child was never allowed in a car seat unless she was actually in the car. She was never allowed in a bouncy seat for more than about 15 minutes because otherwise she would nestle back onto that flat spot. So my kid got carried around in a baby Bjorn, like nonstop, and it worked. I mean, it definitely worked. So when I talk to families about this, I at least am able to say, no, it's not just switching arms when you feed, it's get them off that flat spot. But where we really do run into challenges is developmentally delayed children, kids with significant torticollis, and we've actually seen some issues where kids who have had shunts, and now they've got these funny shaped heads because their hydrocephalus has collapsed. We've actually found molding helmets work really well in some of those patients, although people are usually a little woodgy about doing it. All right. It is my honor to introduce our next speaker. Our next speaker is Glenda Vasquez. She is our Chief of Pediatric Rehab Medicine, and she is going to talk to us today about early detection and early intervention in the patients with cerebral palsy.
Thank you so much. Good morning to all of you. I'm going to be talking about why early is best. I think the context of this, I don't have any disclosures. Sorry, they want me to show you my pretty smile. Let me see. All right. I don't have any significant disclosures. The context for this talk or this lecture is that most children get diagnosed with cerebral palsy, actually between the ages of 2 to 4, and there's reported healthcare disparities that we've seen with reported delays in diagnosis and therefore interventions for children who are Black and Hispanic or Latinx. So hopefully as we talk about this, we can talk about why early diagnosis is important and interventions. Can I go back? All right. CP is the most common physical disability in childhood, and the variation in birth prevalence exists in high-income countries. It occurs because of a lesion, injury, or maldevelopment in the developing brain. Yeah, thank you. I would appreciate it. And it is, though, a clinical diagnosis because there are no biomarkers for the diagnosis of cerebral palsy. Traditionally, it has been diagnosed between the ages of 1 to 2, but like I've mentioned, there are specific populations that sometimes get delays in diagnosis. It is diagnosed because of a combination of pertinent history, clinical signs, neurological symptoms, and physical examination findings. And impaired movement is the main presentation. We can see delayed motor milestones. It's associated with exaggerated reflexes, but we can also see floppiness and or spasticity in infants, unusual postures, and involuntary movements, or a combination of all these. About 10 years ago, there was a reported increase in prevalence. There was noticed that more premature babies were surviving with more motoric impairments. There was an update reported by OSQE in 2018, and he actually reported that the overall prevalence of cerebral palsy has remained constant from 2007 to 2018. However, it probably is because there's a balance between increased prevalence factors, such as prematurity, of extremely very small preemies, and also an increased incidence in multiple birth, and a balance of that combined balance with factors that actually decrease the prevalence, such as the use of antenatal steroids, cooling, or even using mag sulfate. Birth weight risk, actually this is the most, they also kind of like reported an update about this, and birth weight specifically, very low birth weights, less than 1,500 grams is the highest risk for developing cerebral palsy. And then in relation to gestational age, decreased prevalence with gestational age is seen, decreased prevalence is seen with higher gestational age. So the higher risk rates of those with earlier than 28 weeks of gestation. And then we see also very low incidence with infants that are born 32 weeks and older. We've also seen a prevalence declining in Australia and in Europe, but the exact rates in these countries, in countries that have low to middle incomes, is less certain. So we sometimes don't have reports on prevalence beyond developed countries. In terms of etiology, the true cause of cerebral palsy in an individual is most likely a complex interplay between several risk factors across multiple periods of time, including there's new evidence suggesting that even 14% of cases potentially may have a genetic component. The specific pathway that will result in CP is unclear in approximately 80% of cases, but risk factors are often identifiable from history taken about pregnancy, conception, birth, and the postnatal period. In developed nations, the most predominant causes, as I've mentioned, are prematurity, especially lower than 28, and then extremely low birth weight. In developing countries, they're still coping with infections such as Zika, rubella, intranatal hypoxia, and postnatal hyperbilirubinemia. Historically, we have been assessing risk mostly by history taking, identification of risk factors through newborn and infancy and childhood periods. Such as in newborn, we have detectable risks, as I mentioned, preterm. We also have hypoxic ischemic encephalopathy, and just history of either neurological conditions or risks, and then detectable risk in infancy, such as just parental concerns, comparison of development, and once the child is discharged, also the inability to sit by 9 months of age, or hand-arm asymmetry in how they're doing their motor control. All of these things will warrant additional investigations and a full evaluation. Can you just hit the video at 1? Okay, thank you. Oh, I click it?
2-month-old typical atypical motor development side by
I'm just going to
side.
talk. In addition to the medical history and neurological evaluation as just, typical physical examination of infants, there are additional tests that may give us clues. And either they might give us reassurance, right, of the overall development of the child, or it can also give us the ability to identify atypical movements, which may warrant additional evaluation and management. This is just a brief video, an example of motor testing of a 2-month-old. Side by side, we have comparisons of what a typically developing baby is moving, and then atypical signs of movement patterns on the other baby. Actually, this website, pathways.org, provides video examples of general movement testing for infants of different ages, which is a great resource for review for general practitioners and clinicians, and also for trainees, for medical students or pediatric residents.
Begins to show extremity anti-gravity movement.
We also have additional standardized testing. There is the Hammersmith Infant Neurological Examination. It is easily performed and relatively brief, a standardized neurological exam of infants. It has a good intra-observed reliability, even with less experienced staff. So we actually can get people trained, additional clinicians that are not physicians, like physical therapists or occupational therapists on HINE. And HINE can further help identify those infants needing specific rehab programs. It includes 26 items assessing cranial nerve function, posture, quality and quantity of movements, muscle tone and reflexes and reaction. Each item is scored individually. And there's also a sum score of all the individual items. And then we can also have sequential testing. And the use sequentially will allow us with early signs of cerebral palsy and other neuromotor disorders. Individual items can be predictive of motor outcomes. For example, in preterm infants assessed between 6 and 15 months of corrected age, scores greater than 64 predict independent walking with a sensitivity of 90%, and specificity, and conversely, scores less than 52 were highly predictive of CP with severe motor impairments. And this is actually better than the old kind of like rule or a dash sit by 2. So we could potentially diagnose patients around the age of 6 months of a corrected age. And that's an example of the reporting form that we can use as observers. And click it again. And I included in the references the article for HINE, and there's actually, if you can maybe go to like 10 minutes, minute 10. They actually have a link to like their YouTube video of a whole HINE examination. And you can see what it's all about. But it can actually take about 10 to 15 minutes to do a full neurological examination of all these things on infants and have a really good idea if there's any red flags that warrant additional evaluation. So, historically we've had this silence period. From 12 to 20 months of age, we've regarded this period like, well, we'll just watch and see what your child does. However, nowadays, there is we can actually diagnose children with CP, or at least a high risk for cerebral palsy, as I mentioned before, the age of 6 months corrected age. The 3 tools with best predictive validity for detecting CP before 5 months corrected age include a neonatal MRI, the Pratchell qualitative assessment of general movements, and the HINE. After 5 months of age, corrected age, we also can use an MRI, the HINE, or developmental assessment of young children. Late diagnosis means some infants will not receive early intervention when they would benefit the most, because these are crucial periods. So in order to make a diagnosis, we will need a reduced quality of general movements or neurological abnormal movements, which we mentioned as suboptimal Hines scores or early observable hand asymmetry. And these will indicate that motor dysfunction that is required for a diagnosis of cerebral palsy. In infants younger than 2, motor severity is really difficult to predict. So we can see that the child has a motor impairment, but sometimes we might not be able to predict how severe that motor impairment may be going forward. Why is this? It's because almost half of infants younger than 2 actually end up with their GMFCS reclassified. Little natural history exists for this age group in terms of onset and type of motoric impairments. The presence of hypertonia changes and evolves with time, and there is rapid growth and use-dependent reorganization, aka neuroplasticity, in response to caregiver, therapy, and other environmental factors. So cerebral palsy can be classified through motor types. There are 4 motor types that exist. They can emerge and change during the first 2 years of life. The majority of patients are going to present with spasticity, and spasticity may even occur after the age of 2. Lack of presence of spasticity before the age of 1 doesn't mean that the child does not have cerebral palsy, though. We can also see dyskinesia with fluctuating tone, including dystonia and anatosis. We can also have ataxia and hypotonia. Ataxia and hypotonia and dyskinesia tend to be less, they present less. As an infant motor volitional increases, some symptoms may resolve, some symptoms may worsen. For example, this may happen with dystonic posturing. We can also classify cerebral palsy with anatomical distribution. Dyskinesias, ataxias, hypotonia typically will affect all 4 limbs, while spasticity we can classify depending on the limbs that it's affected. We can see hemiplegia or unilateral in about 38% of patients. We can see diplegia, in which the lower extremities are more affected than the upper extremities, in about 37% of patients, and then quadriplegia, in which all limbs are affected. Typically, lower extremities are more affected than the upper extremities in 24% of the patients. Neuroscience evidence indicates that brain development continues postnatally, driven by motor cortex activation. Therefore, activity-based interventions are essential because those infants who do not use their motor cortex risk losing connections and dedicated function. There is increased evidence that the infant's behavior through interaction with their environment help control and generate growth and development of muscles, soft tissue, in addition to the neuromotor system. This is why it's so important to diagnose and detect early so the child can be referred for early interventions. Depending on the ongoing impairment, cerebral palsy-specific early interventions maximize neuroplasticity and will minimize complications to muscles, bone growth, and joint development, and optimize outcomes. Not all ECI programs are the same. They vary in frequency, type of intervention, content, focus of intervention, so therefore no real conclusions can be made about how effective they may or may not be. The ideal duration and frequency of programs and interventions are also not clear. Identification of the distribution of motor impairments early may aid in identifying different treatment strategies to optimize and improve outcomes. For example, studies have shown that infants with bilateral cerebral palsy who receive regular surveillance and intervention have lower rates of hip displacement, contracture development, and neuromuscular scoliosis. On the other side, hemiplegic cerebral palsy, especially those patients who receive CIMT, which means constraint-induced therapy, have better hand function than controls. Also, in infants, interventions at home has shown better improvements overall. A very intense and promising intervention that can be offered at home is GAME, and it's not playing with your child. GAME stands for G, it's goal-oriented, and then A is for activity, and ME is for motor enrichment. So the part 1 is that goal-oriented intensive motor training. Families collaborate with the therapist. They're going to determine a specific set of goals for their child's development. The goals are going to relate to motor development, and the therapists are going to play an important role in helping the parents set realistic and appropriate time frame goals. as goals are attained, new goals are identified. The therapist assess how weakness, selective control, alterations in tone, affect the difficulties that are noted by the family, and then solutions are identified. Part 2 is A for activity, and actually the parent is educated and grounded in family-centered approach, and the parents are going to be coached to identify the child's attempt to activate and volitionally move and self-regulate. They're also educated in potential trajectories to enhance development and stimulate the process. And then the last part is the motor environment or environmental enrichment, in which the interventions are going to happen at home, where they can assess the child's environment and how it may hinder or optimize the child's development, and the parent is coached in regard to toy selection, physical setup of areas, repeating and practicing the activities related to identified goals. And they're going to use typical like baby toys for all these things, so not a lot of like equipment, specialized equipment will be needed at this stage. And then what happens beyond infancy? Even beyond infancy, access to knowledgeable therapists can improve outcome potential and skill acquisition. We want child-initiated movement, target motor training activities, and task-specific and context-specific exercises. This is an amazing chart, but it is very busy. And it has been published in a systemic review of the literature. And the authors basically use a traffic light system after completing this review of the literature for the prevention and treatment of specific impairments related with cerebral palsy. And we're just going to touch base on a couple. However, as a physical medicine and rehab or physiatrist, we can assist in the management of these early interventions for children with CP or at high risk for CP. We will assist with surveillance for hips and scoliosis. We assist in optimizing interventions, making sure that the patients have access to ongoing therapeutic sessions that make sense for the patient and the family. In addition, most patients will develop a specific type of motoric impairment, and the interventions that one child may need may differ from the interventions that another one may need. So basically, we're kind of like, so we assess all these potential interventions and also help explore and tease out with the family which are worth pursuing, which are, who knows, it might help, and which are, you shouldn't even try. So, for example, CIMT, there, the clicks are. CIMT stands for Constraint-Induced Movement Therapy. It includes intensive motor practice with restraint of the uninvolved extremity. There is formal CIMT, in which the child is going to have basically limitation of the unaffected limb with 3 hours of therapy a day for at least 2 consecutive weeks. There's modified CMT, in which requires restraining the unaffected limb for less than 3 hours a day with therapy. And there's also some forced use therapy, which involves restraining the unaffected limb with no additional therapy. So the jury's out on this in terms of frequency and duration. There has not been determined that there is like a right answer between which type of CIMT is the best. We just know that the methods include bivalve cast, storm cast, sling, fabric glove, built-in volar, plastic splints or whatever. We just know that early intervention with this type of rehab on hemiplegic patients with hemiplegic CP actually improves hand function compared to controls. And actually, it started with the eyes, then it's basically a similar philosophy of patching. And when we started doing this in children, we started noticing these changes. So there's actually adult data that shows motor reorganization with this type of therapy. And cases has shown that cortical reorganization in functional MRI in similar patients with adult stroke. So if adults can do it, our kids can do it, and better. So partial body weight support treadmill training is another targeted intervention. It is very task-specific and repetitive, and evidence supports for motor interventions that are goal-oriented, promote task performance, which can be translated and practiced into real-life activities and tasks. So if you're practicing walking, therefore you have a higher chance to be able to walk over ground, right? So that's kind of like where it comes from. We're using self-generated movements and high-intensity repetition and practice. And the mechanism of action is experience or activity-dependent plasticity. Okay. So we see the worth it line and probably don't do it and don't do it, okay? So neuroplasticity is highly affected by motivation and attention. Task-specific practice that is enjoyed and reinforced in the child produces spontaneous regular practice. If the child hates it, probably they don't want to do it again, okay? So if we look at the interventions at the bottom of the chart, we can see more passive interventions, right? The child probably is not engaged in doing. There's a very limited activation of any kind of like motor, probably a lot of like passive repetition or interventions that actually the child doesn't even participate in it in a sense. Because there's no requirement for a child to integrate itself, they really don't have evidence or efficacy for some of these in the red spots. Okay, so we discussed how specific interventions may assist with skill development in children with CP and how important early provision of these interventions may be to unlock the outcome of our patients. So PM&R longitudinally will follow patients with CP and aid in this to prevent ongoing complications such as joint deformities, contractures, scoliosis, among other, with implementation of bracing, identification of appropriate equipment, and provision of aggressive tone and spasticity management. And talking about tone management, so hypertonicity or spasticity is a major contributor to secondary impairments that are going to progressively lead to activity and participation restriction as the child ages. If spasticity is causing pain or interfering with motor development, management needs to be considered. So this figure demonstrates the different interventions that we can provide for children with CP to assist with tone management, contraction and alignment management. And again, the earlier that these are implemented, the less the musculoskeletal complications and related comorbidities, and therefore include quality of life. So through our program, we provide management with all of these interventions, from oral and enteral medication, local chemodenervation procedures such as botulinum toxin. And we always consider child's functional, personal, environmental factors and potential goals in the treatment plan that is developed. In addition to the typical pediatric PM&R, this year we actually launched the combined spasticity clinic, or the combined advanced pediatric spasticity clinic. And this is going to be used to enhance and centralize the management of patients who present with spasticity and other movements. So the child will get a comprehensive evaluation for management and optimization of rehab interventions, including skill acquisition and mobility. So as part of this comprehensive eval, the patient is evaluated by all team members, including a pediatric physiatrist, a pediatric neurosurgeon, physical therapy, and occupational therapy. We have a rehab coordinator for this clinic and a social worker. And our team discusses our findings and will provide recommendations. And hopefully in the future, we would have access to gait lab analysis and other evaluations that can target interventions a little bit better. So takeaway points, collaborating to develop a follow-up clinic with trained clinicians for high-risk patients may actually systematically identify patients as less than 1 year of age, hopefully around 6 months of corrected age. Not all rehab interventions are the same, and early referral can assist with joint surveillance and maximization of tone management to decrease impact in function, and these things are essential for improvements of outcomes in this patient population. Thank you. Any questions?
how do you counsel families who ask about things like stem cell therapy and hyperbaric oxygen? I know those were in the yellow and red of that chart, not really recommended, but what do you actually say to them?
Yeah, it is an interesting topic. It is difficult sometimes to navigate these with the families. I typically talk about how my responsibility as part of do no harm sometimes is do no financial harm, and that some of these interventions are actually not as innocuous as we think they are. I think a lot of people have forgotten that back in the 70s and 80s, hyperbaric chambers will explode and kids died. There can also be viral trauma. A lot of our kids may have pumps, and it can affect actually pump function. Like the metal can actually, because of the changes in pressure, they can dent. So I do my best to kind of like answer questions. At the same time, I cannot penalize the families that want to do it. I try to think of it as what are the other things that the child would need and how can I help? So yes, you're going there for hyperbaric, but are they getting therapy? Are they doing these things? Because not having the standard of care may actually affect the child. So that's as much as I can do in a sense. Unfortunately, if we actually talk with these families, a lot of data they're getting are from their own peers, and scientific data, it's really not prioritized when they make this decision. So even if we come with, hey, there is this nice chart and look at the scientific evidence, there has been a shift in the scientific value for these families, and the values may just be different.
Thank you so much for your talk. I'm wondering, for pediatricians in the community, when they take care of kids with cerebral palsy, what types of patients are good to refer to your clinic, and how do they kind of differentiate? Where do they go to a general neurologist? Do they come to you? Where does that process lie?
Yeah, I'm smiling because I'm actually writing a manuscript about just that, about what's the difference between PD neuro, PD ortho, because we tend to treat the same patient population. I see us as like the functional, part of all of these things, especially kids that have motoric impairments, mobility issues that require advanced equipment, advanced interventions. That's our language. We know that not all therapy is the same. We know that not all wheelchairs are the same. We know that not all braces are the same. We're specifically trained on these things. And we also manage non-operative a lot of these alignment issues, tone issues. So hip surveillance, the diminishing musculoskeletal deformities, that's also what we do. So I typically see, and correct me if I'm wrong, almost all kids with CP, if they have some sort of motoric involvement and or spasticity, probably should be seen by a rehab physician, because that they look fine when they're younger doesn't mean that they're not going to develop a contracture as they age, or that they don't need a brace. And kids are going to move, and they're going to do weird stuff with their body. And then I see them when they're 12, and I'm like, I wish you would have seen me 5 years ago, So that's kind of like how I see it. Sometimes they send me kids with CP that are doing everything though, just because they have CP. And they maybe have a very, very, very mild hemiplegia at the age of 14. And if they don't have any tone contracture or any issue, I'm like, okay, I'll talk with the family and I'll be here just in case. But, and then I see patients that I directly send to ortho, for example, but ortho may not have the time to discuss a lot of these functional environmental issues, and the family think that the kid is getting everything that they need just because they're seeing a physician. So kind of like, and sometimes kids just need additional diagnostic workup. The people love to send me toe walkers, and I'll see toe walkers, but not all toe walkers because of cerebral palsy. So, and then I'm like, hey, have you seen our friendly neuro doctors? So that's kind of like how I see it. And then developmental pediatrics, sometimes they send me kids with autism, and that's more of a cognitive intellectual, and I may be a little bit equipped for that, but probably they should be seeing developmental pediatricians or neurodevelopment for that, because of the lack of that motoric mobility issues.
I had a question about what is your threshold, because you mentioned earlier not all therapies are the same. What is your threshold to refer to additional therapies once a child is maybe already getting ECI services? Is there a certain age at which you say they should be getting more, like a certain frequency per week, or are you gauging it based on their progress in therapies? How do you approach that?
For me, ECI is for kids that are almost near normal or normal and just at risk. So they can provide developmental guidance and play for families. I do think that kids that already have neurological impairments will be better served with either home full therapy or outpatient therapy. Typically, though, I tend to wait until the age of 1 to really kind of like push for outpatient therapy, unless there is a high kind of like knowledge gap in terms of the home therapists that are being provided. Also, not all home therapy programs are the same. There are some therapy programs that are basically coordinated by a home health company, and they're based off nursing, and there might not be a lot of guidance and support from knowledge and interventions from their leadership for therapists. So you can end up having adult therapists in kids because there's really no limitation for that. And there's some home therapy companies that are actually therapy built, like the leadership are therapists, and they expect specific kind of like competencies from their therapists. So therefore, my clinic appointments take forever because sometimes I like engaging the therapist because it's an access issue sometimes. So sometimes I prefer to access therapists and see if we can change the interventions. If we're not going anywhere, then sometimes we just need to rewrite that plan. The other thing is that families think that they can be in therapy forever. And then they may have like 20 visits a year or something like that. So it's kind of like the understanding that skill acquisition happens with repetition. Diluting 20 visits in a year doesn't necessarily lead to skill acquisition. And there's also a need for accountability and responsibility for parents. They need to start learning home exercise programs early, because once the child turns 18, they turn into a pumpkin and they cannot access the pediatric services, and then the families were never trained after 18 years of therapy interventions. So I sometimes tend to do outpatient bouts, home therapy, home exercise program. It's basically used almost like a medication, like you have different doses and concentrations, and one therapy intervention may help skill acquisition, et cetera. So that's how I see it.
Thank you. Can I actually ask you one more? What have you seen over the course of the pandemic in terms of, one, obviously a lot of therapies are happening virtually. Are there any good resources online or videos that you can recommend to families who are wanting to learn to do some of these things themselves?
That has been difficult, and it actually has been reported in the literature how COVID pandemic has affected conditioning, access to therapies, and even function in our kids. Virtual therapy is not the same thing as real therapy. Then it's also compounded by not going to school, and I think we really minimized activity, just transferring to the wheelchair, getting to school, staying awake, moving, maybe getting into a standard in school or something. Like our kids really develop contractures, a lot of chronic pain, hips popping out of socket because of access issues. It's important to keep kids in a routine. And that's why I've always believed in accountability for parents, because if they have known home exercise programs, it would have been easier than to be the hands of the therapist and to help their kids at home. I think we are very busy, so there's like, oh, he's doing therapy, I don't need to learn any of this. So these are things that I really talk to parents about to integrate it in their home life and their routines. Thank you.
I have the pleasure of introducing Dr. Sarah Pavitt. She did her training at Stanford and a headache fellowship at UCSF, and is now the chief of our pediatric headache division. So welcome and thank you.
Thank you. Thank you.
right, thank you guys so much for having me. I have the joy of talking about pediatric migraine today. All right. From financial disclosures, I sit on an advisory board for Theranica, which is a neuromodulation device, but it won't be relevant for today's topic. By the end of the lecture today, you should be able to list important features of a headache history and physical exam, define diagnostic criteria for primary headache disorders, describe the epidemiology and impact of migraine, and then compare migraine options, treatment options, in pediatric headache care. When I think about approaching a headache patient who comes to see me in clinic, I really guide my history and physical exam to really try and tease out, is this a primary or secondary headache condition? And this includes looking at every single part of the history and physical that we're trained to do. So it's looking at the timing and onset. Is this acute? Has this been something that's been going on for years? The different pain characteristics, associated features. So what other symptoms are occurring when the patient is having a headache? Really important is getting a prior headache history. Oftentimes patients will come in and say, I've never had a headache before. If you kind of probe, no, they've actually been having headaches since they were 4 or 5, and now they're just getting worse. Maybe it's puberty, and that's the thing that's triggering their increase in headache frequency and different associated features. I do a complete review of systems from the neurologic perspective to look at other associated features, along with a systemic review of systems to think about any other secondary conditions that may be contributing. Finally, going through all of your past medical history, really important, assessing family history. Oftentimes, I'm making the diagnosis of migraine in parents during my initial clinic appointment with them. And finally, the physical exam. Most important, we do a full neurologic exam, but the fundoscopic exam is one of those things that should be done in every patient that comes into your clinic with headache. So as I do this history, as I complete the physical, I'm really trying to think in my mind, what are those red flag symptoms that would maybe point me to a secondary headache condition that I'd need to do further imaging? So when I think about that, these are my acute kind of secondary red flags. Acute onset of headache with worsening pain in a short period of time. Worst headache of life or thunderclap headache, which makes you think about a subarachnoid hemorrhage. A positional component to headache, making you think about a CSF, either too much CSF and causing increased intracranial pressure, or a leak causing low pressure. Headaches that wake patients from the morning or from sleep, or triggered by Valsalva, also a sign of increased ICP. Side-locked headaches, which can be a sign of a pituitary abnormality or something like a meningioma, or any focal neurologic deficit. There are, though, some red flag myths that now have really thought to be outdated. So the idea of an occipital headache with the location of the pain. This used to be a red flag that many patients or many providers would get imaging for. But they've done large studies in the emergency room looking at patients who come in solely with occipital headache. And while they do have increased incidence of abnormal neuroimaging, all patients had an abnormal neurologic exam. So if I'm seeing a patient in clinic with an occipital headache, it makes me take pause. I do a very detailed neurologic exam, and if that exam is normal, it is not a red flag that makes me think we need to pursue head imaging. Headaches with associated cranioautonomic features are another red flag myth. In the 90s, many patients were actually diagnosed with sinus headaches and were undergoing sinus surgeries. A lot of studies have been going on to figure this out, and really what happened is that migraine is associated with cranioautonomic symptoms, nasal congestion, runny nose. So it's not that the sinus problems were leading to headaches, but they were just having migraine. So even after having sinus surgery, they continue to have these episodic headaches with these associated symptoms. So let's run through a case quickly. This is AJ. She's a 14-year-old female. She has a past medical history of seasonal allergies and asthma, and she's presenting to your clinic with a headache evaluation. Headaches have been occurring for the last 3 months. They started with 1 headache per week, and now they're increasing in frequency. It's bitemporal pain, 2 to 3 months, episodes a month are severe. They normally start in the morning right upon awakening. She opens her eyes in the morning and she has a headache. They're associated with photophobia, phonophobia, and nausea. And she's noticed over the last 2 weeks, not only are they tending to start more in the morning, she's also having associated nausea and some vomiting in the morning right upon awakening. So in this specific case, there are some red flag features. These headaches have been going on for a shorter period of time. They've rapidly increased in frequency. And now you're starting to get some concerning features for increased ICP, with headaches starting in the morning upon awakening and nausea and vomiting along with these headaches upon awakening. So with this patient, we end up deciding to get an MRI, which returns normal. So then the question is, what is our diagnosis for this patient? And when I think about primary headache disorders and making diagnoses, our manual is the International Classification of Headache Disorders. We're on our 3rd edition. This website is free. Our classification system is free to download. I encourage you all to do it. If you have any questions on where does my patient sit? What diagnosis should I be giving them? This is where you need to go to look up information. So I want to talk about 2 different primary headache disorders, the most common 2. The first, tension type headache. So to make the diagnosis of tension type headache, patients need at least 10 attacks in their life. These headaches last anywhere between 30 minutes to 7 days, so they can be incredibly long. And you have to have 2 plus 2. They need to have bilateral pain. It's typically pressing or tightening when you ask the quality of the pain. It's not aggravated by physical activity, and it's mild to moderate pain intensity. I think about these patients as kids who will complain or report headache, and then they can still do whatever they want to do in their life. It doesn't slow them down. They don't have to stop doing their activity, but they notice this mild headache. For associated symptoms, it cannot have nausea or vomiting. As soon as you have nausea associated with headache, you can no longer make that diagnosis of tension headache. You can also not have more than one of either photophobia, sensitivity to light, or phonophobia, sensitivity to sound. So only one of those associated symptoms. This is in contrast to the diagnosis of migraine. You need to have 5 lifetime attacks. Attacks need to be anywhere between 2 hours and 72 hours, and you need to have 2 plus 1. Pain can be bilateral or unilateral, typically throbbing or pulsating in quality. I often hear it feels like I'm getting hit in the head with a hammer. I feel like my heart is just pounding in my head. It is worsened by activity and moderate to severe in intensity. So these kids aren't able to continue doing what they're doing. They have to come and rest. They need to go inside. They come home from school. For associated symptoms, nausea and/or vomiting. And then they have to have photophobia and phonophobia. They need one of these 2 criteria. This is different than diagnosing adult migraine. I just want to highlight where these differences lie. Kids have shorter headaches. So in adult migraine, they need to be at least 4 hours. In pediatrics, it's 2 hours. Oftentimes in children, our pain is bilateral. So kids, it can be bilateral, where in adults, after puberty, we tend to see evolution to more unilateral pain. One of my favorite things is I get to infer the associated symptoms. So if you ask kids, do you feel sensitive to light and sound? Almost all of them are going to say no. So I don't ask that. I say, what do you want to do when you get your severe headaches? The majority will say, I want to go lay down in my room. Are the lights on or off? Oh, they're off. Do you want to close your door and have things quiet? Yes. If I'm getting no, I have nothing, then I'll ask some extremes. During a severe headache, would you want to be outside in the bright sun? Oh, no, I could never do that. Would you want to go to a football game or a pep rally or a rock concert? Oh, no, I could never do that. So these are inferred, and it's important in your history to really dig down about these associated symptoms so we can make the correct diagnosis when we're seeing our headache patients. So for our patient case, AJ, who had a normal MRI in that history, her diagnosis is migraine without aura, and she's in an episodic range. So let's talk a little bit about migraine epidemiology in general. Migraine is incredibly common. About 39 million people in the United States have migraine. It is the third most common illness worldwide and the second leading cause of years lost due to disability. This is in adult patients. It's a really under-recognized and underrepresented diagnosis. And when we think about it in the pediatric population, we'll get into this more, it causes significant disability in our children. The overall prevalence is about 12%, and after puberty is much more common in females than males. Before puberty, it's about a 1-to-1 ratio. And what about chronic migraine? I hear this all the time. There's no way that my kid could have chronic migraine that's not a childhood disease. That's not true. In adults, about 1% of adults have chronic migraine. In kids 5 to 12 years old, 0.6%. And anywhere between 0.8 and 1.8% of adolescents and kids 12 to 17. So these kids, this diagnosis exists. It needs to be identified and treated early. When we look at specifically pediatric migraine disability, we know that children with migraine tend to miss more school and perform more poorly in school than their headache-free peers. We also know that there's a dose effect. So for those kids who have more frequent migraine, chronic migraine, they tend to miss more school than their peers with episodic migraine, which again is why it's so important that we start treatment. Nausea is the highest predictor for missing school. And so now in our guidelines, any patient who comes to you with nausea as part of their migraine syndrome, they need to have nausea treatment offered to them. We know that children from socioeconomic disadvantaged backgrounds are 4 times more likely to have chronic migraine. And chronic migraine in the pediatric population has similar disability to rheumatoid arthritis and pediatric cancer. So let's think a little bit about the pathophysiology. It's a very complex genetic disorder, and it does tend to run in families. There's about 40 genes that have already been identified in migraine, and if you have one parent who has migraine, you're about 50% chance of having migraine yourself. Both parents, that bumps you up anywhere between 60 and 80% chance. When I talk to families, I talk about having that migraine gene, that genetic change, actually makes your nervous system more hypersensitive than someone who doesn't have migraine. It has a harder time processing all the sensory information in our environment. Sounds, light, stress. The migraine brain has a harder time processing that, and when it gets overloaded, it triggers migraine. I'm actually gonna skip that part. And when we think about that triggering, so those triggers are cumulative, we have this event, this migraine event, what happens? It's a very complex neurologic process where we see changes and alterations in the vasculature of the brain. That in turn releases a neuropeptide called CGRP. Many of you have probably heard commercials about this. It's really important right now in the pathophysiology of migraine and a new target for medications. But that CGRP really interacts with the trigeminal nerve, and that nerve talks to the hypothalamus, the thalamus, and cortical regions, which give us all of the symptoms of migraine. I talk about migraine and not about headache, because migraine is so much more than a headache. When we think about having a migraine attack, these are the phases that we tend to think about. There's a predominatory phase where patients will start to experience cravings, yawning, they get fluid retention, and they get this heightened perception. Oftentimes, that may look like sensitivity to light. Why do I all of a sudden feel sensitive to light? This is strange. My migraine is starting. About a third of patients will experience aura. This can be visual changes, sensory changes. You can get weakness. You can get confusion, difficulty speaking. And then comes the headache phase. During the headache phase, we tend to see those associated symptoms: nausea, vomiting, light sensitivity, sound sensitivity. We can also get a lot of other focal neurologic deficits. You can get dizziness, vertigo, high-pitched tinnitus. All of these are very common within that headache phase and typically where we see the most disability. Then it comes the postdrome. So this phase of almost complete exhaustion of your body recovering from the attack that it's just experienced. And even interictally, between migraine attacks, patients can still experience symptoms. They can still have some of that light sensitivity. And you're sensitive to those triggers. So even in that interictal phase, patients still may be experiencing certain symptoms. When we think about aura, it occurs in about 30% of patients. And to have aura, you actually need to have a symptom, tends to be visual, that starts and spreads over time. It has to last at least 5 minutes and spread. So tends to, I always get the example, is it all of a sudden in your visual field, you're like, I think I'm seeing a dot in my vision. And then 30 seconds later, oh no, it's definitely there. And then it grows and grows. They tend to be positive symptoms rather than negative symptoms, so paresthesias, seeing rainbows, rather than loss of sensation. Visual aura is the most common, and then comes sensory, and then language. High-frequency primary headache disorders, I want to briefly talk about. So the diagnosis of chronic migraine. Making that diagnosis is any patient who's having more than 15 headache days a month for more than 3 months. And those, you need to have at least 8 migraine attacks. Like I said, migraine attacks can be long, and so at least 8 discrete attacks with 15 headache days per month. That's in contrast to new daily persistent headache. This is an interesting headache disorder where patients have a remembered onset of headache. And they will tell you, on February 5th, I woke up and my headache pain has been daily and continuous since that time for at least 3 months. It has not gone away. I've had no pain-free moments. These are really the 2 primary headache diagnoses that you'll make. Daily chronic headache used to be a term, and that term is now outdated. And really, these patients will fall into either chronic migraine or new daily persistent headache. So let's talk about migraine treatment and how to think about these patients once you've made that diagnosis. It's really important to screen for any secondary causes that may be increasing our migraine frequency. So when I see these patients, we think about vision and do a vision screen. I screen for obstructive sleep apnea, especially for patients who are having morning headaches. I consider lab work with a CBC, looking at electrolytes and thyroid studies if they have any symptoms. And then I screen for mood disorders and really try and establish care for these patients early on. Anxiety and depression have higher rates in patients with migraine, and we know that that plays into the pain cycle, which Dr. Parker will talk a little bit about in the next talk. Education is incredibly important, not only for patients, but for parents, for schools. The headachereliefguide.com is a free resource. I give this to all of my patients. They can go, it's interactive. They can learn all about what migraine is. There's videos. They can go and kind of create their own migraine treatment plan. And for medical providers, you can actually make very specific treatment plans based on your patient's demographics. Then I talk about the treatment pyramid, and I'll draw this out for patients. I tell them that the foundation of migraine treatment is really lifestyle regularity. That migraine brain likes things to be regular. And that's regularity in kind of 4 main domains, with sleep, hydration, meals, and exercise. Maintaining adequate sleep can be very difficult, especially in adolescence when circadian rhythms are shifting, and naturally teens want to go to bed later and wake up later. Yet many high schools, many middle schools are starting before 8 a.m. So it's fighting against that natural change in sleep. But we talk about maintaining a consistent sleep schedule, where actually we know the wake-up time is more important than the going to bed time. And I try and say between weekends and weekdays, only 2 hours different. Hydration, hydration, hydration. Especially here in Texas, it is so hot. I sometimes won't even give limits. I just give minimum amount of water and say, please just keep drinking. And if you're feeling a headache, come on. You're outside, drink a big bottle of water and get into some shade. Avoiding meal skipping. Breakfast is the most commonly skipped meal. So we talk about strategies, workable strategies for patients to incorporate breakfast, something portable, something small, but that migraine brain wants something in your stomach at scheduled times 3 times a day. And then exercise. There's a really great study done in the adult population where they asked patients with migraine to either exercise 40 minutes for 3 times a week or take Topamax every single day. Both groups had the same reduction of headache frequency. This shows the importance of exercise and getting out and having moderate exercise multiple times a week. I talk about this not in a sense of blaming a patient and trying to make this approachable for them. So if we have areas where we could improve in each one of these domains, pick one or two. Find things that the patient feels motivated to change and start to make those changes. We then start talking about prevention. When I think about headache prevention, the whole goal is to calm down that hypersensitive brain. And we should really start thinking about this in anyone who's having more than 4 migraine days per month. We know that when we combine medication therapies with behavioral therapies, it is the most effective treatment for migraine. And I can't overstate this enough, that we need to have behavioral therapies for these patients. My approach is to start one medication at a time, and if it's not effective, then we stop it. I sometimes come in and patients will be started on 4 or 5 vitamins at a time, and then they're better, but I have no idea what made them better. And each of these still have side effects. So one at a time, and if it's not effective, we change. An adequate trial does take 6 to 8 weeks, and it's important to tell families this. Oftentimes I'll have families come in and they tried a medicine for 3 days and they said it didn't work. It's not going to work in 3 days. It takes time. And I tell them that our goal is a 50% reduction in their headache frequency in that 6 to 8 weeks. My approach after the CHAMP trial came out, which was a randomized control trial, really trying to assess the efficacy between amitriptyline and Topamax, but it was a randomized control trial of amitriptyline, Topamax, and placebo in episodic migraineurs, pediatric migraineurs. All 3 arms saw the same headache reduction. I could spend an hour just talking about that trial and how to interpret it in clinical practice, but what it changed for me is that I first choose a preventive treatment option that has the closest side effects to placebo as possible. And so in migraine, we're really lucky that we have 4 nutraceuticals or naturally occurring vitamins that we know, if given every day, help reduce headache frequency. These are the 4: melatonin, riboflavin, CoQ10, and magnesium. And I really kind of base which one we go to on the patient's age. So can they swallow pills or not? Magnesium and melatonin both come in gummy form. And then other side effects. So are they having any difficulty with sleeping, which melatonin could help? Or are they having constipation, where maybe adding magnesium at night could be helpful? Once I try a nutraceutical, I next then tend to move to a pharmacologic agent. And these are considered our first lines with propranolol, amitriptyline, and topiramate. I will say that topiramate is the only FDA-approved migraine preventive in children. It's approved down to 12. So every other medication that I am speaking about right now would be off-label. I just put this up here to show you that there are so many options, and these options are growing for patients. And this is my life. This is what I love to do, is figure out what is the best next treatment option for my patient. So I often will have patients come to me, and the treatment options are so large right now in headache medicine. So this is kind of where I view my part in getting involved and really figuring out the next best step. So then let's go to the acute therapy. So what to do, what to take when you get a migraine. Acute therapy should be offered for all patients when you make that diagnosis of migraine. Once you make that diagnosis, it should be part of their treatment plan. And we know that when you treat early, it's most effective. And I want to encourage you to maximize the dose. I tend to start middle of the road for some of these medications to make sure they're tolerated, but then I increase and maximize the dose based on their weight. I also tell every patient that you need to try these medications on 2 to 3 attacks before we say if they're effective or not. Just because it doesn't work that first time, we need to try it again. In the pediatric population, our guidelines say to start really with an NSAID. And typically I start with an naproxen with anyone who can swallow pills. If we can't swallow pills, the naproxen liquid tastes terrible. So I do not have good compliance with that. So then I do ibuprofen. And then I add on a triptan if that NSAID is not helpful. There's 7 different triptans available. 4 of them are approved in the pediatric population. Rizatriptan is approved down to kids to 6. For these ones, trying to think through which one to start, I again think about route. Can they swallow pills? Do they have a lot of nausea? So something like a nasal spray would be a better option for those kids. And then anyone with nausea should be given an antiemetic. I typically start with Zofran, an ODT Zofran, and often with these kids who have upfront nausea, I say take your Zofran first, and then take your triptan with your NSAID together. We know that by combining your NSAID and your triptan up front, that's more effective than waiting and doing a stepwise approach with NSAID first and then triptan. I briefly just want to talk about the Headache Center and the headache program that we have here at Dell, because it truly does take a multidisciplinary team to treat these patients, especially patients who have some of the more refractory primary headache disorders. So I feel very lucky to be working with a wonderful group of people. Chelsea White is my nurse practitioner that I work with. I have 2 amazing pain psychologists, Dr. Parker and Dr. Heckler. I also work with a pediatric physical therapist who is trained in pain, Bruce Morgan. And then we have an amazing set of coordinators, social works, and clinic nurses who really help to make this program wonderful and work for our patients. So we see patients, any headache patient under 18, and we do a full range of treatment options. So I would say if you've tried a nutraceutical and it's not working, I'd love to see these kids. I'd love to see these kids at any point where you're feeling like they need higher level of care. But we do everything. We also do all the neuromodulation options. We do procedures, so occipital nerve blocks as well as Botox in patients that would qualify for that. We also have access to an infusion center to try and keep kids out of the emergency room and give them the IV medications within the infusion center if needed. We have an interdisciplinary program in which patients will meet with myself and then our physical therapist and our psychologist to initiate cognitive behavioral therapy. And then we also have clinical trial opportunities as well as a fellowship because I think with any part of medicine training, the next generation is incredibly important. So with that, I'd love to take any type of questions that you all have.
So what is your advice for acute treatment in children that have 4 or 5 headaches a week and the threshold for medication overuse headache?
Great question. So for those patients, any patient with my chronic headache disorders, we talk about prevention. Prevention, prevention, prevention. Because that is the thing to bring that headache frequency down. When I think about what to take as needed, I tend to use kind of a variety of options. Ibuprofen, Tylenol, triptan. So ibuprofen and Tylenol, if you take them more than 15 days a month, can lead to medication overuse. And triptans need to be limited to 9 days a month. Other over-the-counter medications like Excedrin, 10 to 15 days. Naproxen, though, Aleve, because of its longer half-life, they've actually studied it up to 9 weeks daily, and it doesn't show that there's any signal for medication overuse headache. So for those patients, for most of my patients, I tend to start with an naproxen because I'm less concerned about that medication overuse component. And oftentimes, if I'm seeing someone with high-frequency headache, I'll actually put them on what I call a naproxen bridge, where I do daily naproxen twice a day for 2 weeks while that preventive is kicking in to give them some relief. And as that prevention kicks in, hopefully our headache frequency is also reducing. I do tend to give them a triptan, but we talk a lot about limiting that use to less than 9 times a month. And then the other really nice adjunctive therapy is either a nerve block or neuromodulation. We haven't seen any concerns for medication overuse with any of our neuromodulation devices. So that's a really nice adjunctive therapy in my patients who I'm concerned about medication overuse.
Thank you, Dr. Pavitt. Wonderful talk. We have a question or a comment in the chat about CBD oil. Can you speak to that, please?
Great. Is there a specific or just
No,
CBD
just
and migraine?
Asking for a comment.
So this is a very controversial topic, and it's really interesting. There's our National American Headache Society meeting in June. Most of the program is dedicated to CBD and other psychedelics in headache care and primary headache care. When you look at the literature, it really hasn't proven either way. There are some studies that look like maybe some CBD or THC could be helpful. And if you look at really kind of some basic science models in rats, it looks potentially promising. But there are other more well-designed clinical trials where it didn't look like there were any differences. So my approach right now is that I don't really have any strong recommendations either way. I will say I have some patients who've tried CBD oil and they feel like that's the thing that's helpful. But I also tell patients, anything you put in your body is a medication, and anything you put in your body can have side effects. So specifically with CBD oil, I don't have enough information to say that I recommend it, but it's something where if you're trying it, understand that there's side effects, and so we need to be careful about anything that we're putting in our body. There's a question in the back.
Dr. Deputy for the most questions. I have 3 actually. So my first one is there any role for cyproheptadine in prevention, especially if they've got abdominal symptoms?
Yes, great question. So cyproheptadine, I actually really like for kids under the age of 8. It comes in a liquid, which is really nice. And so in kids under the age of 8 is where I tend to use cyproheptadine. In patients with abdominal migraine, that's where actually a lot of the literature comes around for the use of cyproheptadine is all in abdominal migraine. So I use it in patients too who have a lot of those abdominal migraine symptoms. And when you think about the natural evolution of migraine within the pediatric patient, we didn't talk about that today, but before adolescence, pediatric patients tend to have much more prominent nausea and abdominal pain. As they go through puberty is when we tend to see the more kind of what we call common migraine come out with more head pain emerging, and that nausea vomiting can kind of subside a little bit.
And my second question is a role for Toradol shots in the office for when they haven't been able to get control of it with their home products.
I think it's a great option. Sometimes we need to kind of have this rescue plan for patients. So oftentimes I'll use dopaminergic medications either orally, or if you can get Toradol injections within your office, I think that's a great option. We feel very lucky that we have access to the infusion center, so I can do it from an IV formulation. The one thing I'll say with the Toradol injections is just make sure that you're not doing it too often so we're not running into that medication overuse.
And the last question is that if we need to get somebody to your infusion system center, because usually it's an acute sort of situation, so it's like, to be able to either go from like my office to the infusion center like that day, is there a process for that?
It's a great question. Right now, the way that process is working is that we're really having it reserved for patients who are established within the headache program. But I encourage you, if you have patients who you feel like would be beneficial, the infusion center would be beneficial, don't hesitate to reach out to me, reach out to our clinic. We can get patients in urgently, see them, kind of identify what they need, and get them into that infusion center protocol if we need to. Yeah, send them. I would love to see them in clinic. We can send in the referral. And if there's someone urgent, just call the clinic. I'm happy to speak with anyone in the community about patients that you're concerned about.
I've had several families ask me, when you're starting a preventive medication, especially with the nutraceuticals, how long, because I'll counsel them, it's going to take several weeks before we're sure if this is going to work or not. How long until they might see some effect is a common question I get. Like, I think they're looking to see, how soon should we abandon ship or add something new? What is the soonest you tend to see a response?
Each patient's different. I tell all families 6 weeks. I say, I don't expect any benefit from until 6 weeks. If we see something before that, it's wonderful. But just because you don't see something at week 3, at week 4, week 6 is where we tend to really see the benefit from it.
So on the other side of the equation, if they're doing well, they're meeting their criteria, how long do you treat for?
Great. So when do you wean prevention? So that migraine brain, that hypersensitive nervous system, likes things to be stable. So my approach is a really good 4 to 6 months on stable prevention until we wean and we challenge. But I tell every family, that's a common question I get, am I going to have to be on this medication forever? My hope is no, and our goal is no. And so once we're at that stable time frame, 6 months, 4 months, depending on how long their headache process had been going and how frequent it had been, then I give everyone a trial to wean off. Okay, thank you so much. And I have the incredible honor of introducing Dr. Delana Parker. She is a pediatric pain psychologist. She did her PhD in clinical psychology at UCLA before doing a pediatric pain fellowship at Stanford. So we were at the same institution, which was great. And we have been incredibly lucky to have her as part of our interdisciplinary program. And today she's going to talk about behavioral pain management for pediatric headache.
Okay. Thank you so much. I'm really excited to talk to you all about pain psychology and the role that that plays in managing pediatric headache disorders. Oop. Go back. Okay. All right, no disclosures. So my goals here are to just give you a brief overview of what behavioral pain management looks like and to talk a little bit about how to successfully make a referral and talk about this issue with patients. So in behavioral pain management or pain psychology, we're really focusing on, we'd like to see reductions in pain, of course, but we're also thinking about changing the thought processes, assumptions, beliefs that contribute to pain, pain-related behaviors, physiological processes in the body, and then the social context that really can play a big role in pediatric headache disorders. So we have good evidence for CBT in kids with headaches. So certainly it is effective in reducing pain intensity and frequency compared to things like a waitlist control, but also we know that there's added benefit to adding it in with a preventive medication. And so this is a summary of the meta-analyses that look at RCTs in headache populations, and we see that CBT emerges, and then within that, specifically the components of biofeedback or relaxation, even when pulled out of CBT treatment, can be effective alone. So what is cognitive behavioral therapy? It's a type of therapy that is based on the premise that psychological problems are influenced by faulty patterns in thinking and learned patterns of behavior. So we're really looking at behavioral principles and applying them to individual people to help create change. So there's lots of empirical support across a wide range of conditions in both kids and adults. It's a present-focused treatment, and it's time limited. So the idea is that we're trying to teach a set of skills and a way of thinking that can generalize to life and be carried forward beyond treatment. Okay, so I just briefly want to touch on or acknowledge that there are lots of different treatments that are showing promise, psychological treatments that are showing promise in kids with headaches. So some of the other ones to note are mindfulness-based stress reduction, acceptance and commitment therapy, dialectical behavior therapy, motivational interviewing techniques, clinical hypnosis, And then, of course, many pain psychologists play an important role in just really being a liaison for the care team and coordinating treatment with the family, the patient, and the school. So each of the treatments that I've listed there, these are all types of behavioral therapies. And so it's important to remember there's lots of different CBTs, and I'll be really focusing just on pediatric pain and headache in particular. So our treatments can be delivered in an individual setting, a group setting, and then there are lots of options for self-guided treatment through things like books and apps. Often treatment is delivered in the outpatient setting, but it also plays a really important role in pediatric pain rehabilitation programs, including ones that are sort of follow the intensive outpatient model and some that are on the inpatient setting. And increasingly, we're seeing rehabilitation programs that are headache specific, which is really exciting. So who is this most appropriate for? Because we know that there are lots of children with headaches, and so we really want to think about adding in the behavioral pain management when there's compromised function or significant distress for the patient and or family. And especially we want to target kids when we're starting to see that things are chronic, because we know that in terms of pain processing, that has implications for sort of what's changing and what we need to target. Absolutely, if the child has more than one chronic pain issue, that really tells us that they're at heightened risk for poor outcomes, and we want to get behavioral health on board. So often this issue of comorbidities comes up because things like anxiety disorders and depression are extremely common. Headaches are extremely common as well. And so understanding and untangling sort of what has led to what can be a piece of treatment. But when we see that really it's an anxiety disorder, something that is really separate from the headache process, it's not really so much involved in the pain, then we want to think about just general cognitive behavioral therapy with a community provider rather than pain-specific psychology. And sometimes it's not clear, and part of the job is just sort of untangling that and making appropriate referrals. There are some clinical concerns that really we have to manage before we can think about pain psychology for headache. So certainly things like suicidality, severe depression, and eating disorders. And these are all cases where we really absolutely need to have and connect the family with treatment prior to starting behavioral pain management, where we're really focusing on function. The first piece is assessment and engagement, and this is a very important role, very important part of the treatment planning process and helping sort of to craft an interdisciplinary care plan. So we know psychological factors can trigger, exacerbate, or maintain headache disorders. And some of these psychological factors will be very specific to headaches or pain. And then some are just predisposing factors or comorbid conditions that exist alongside the headaches. During this assessment phase, we also really want to focus on identifying resilience factors and thinking about what are the strengths this patient and family has, and how can we generalize this to the headache context? So where are they coping well, and how can we extend that to this problem? We also want to assess readiness for pain self-management. So this is a huge issue. Not every patient or family that would benefit from pain psychology is ready for pain psychology. And so thinking about many of our patients and families come into clinic and really expect that there's a pill or that they're going to see their doctor and the headaches will be gone and they won't have any more pain. And so absolutely we want to first understand where they are in that process and then help shift them towards an understanding that there's actually lots that they can do that will help them feel better, help them cope, help them actually change the course of their headaches. I'll also note that parents and children might be in really different places in this dimension. So sometimes kids might be more willing to start making some of those changes, but I see a lot of parents who really feel like children shouldn't have pain. and kind of helping them understand and get ready to participate in the process is a first piece of treatment. So these are the components. I'll go through each one briefly, but you can see that we kind of start with this education and pain neuroscience piece and then shift into some of the CBT components. So specifically working with thoughts, thinking about changing behavior, specifically targeting some of the physiological changes that we see in headaches, and then the social piece, so changing some of the environmental contingencies that might be maintaining headaches, and then addressing some of the social modeling that can occur with pain behaviors. So we already saw the headache relief guide before, but in this phase of treatment, we really want to check in with patients and make sure that they understood what was shared with them by their neurologist, that they understand what the symptoms and their diagnosis are. And part of this is also to make sure that we're addressing any diagnostic uncertainty, and I'll talk a little bit more about that. But that can be a major barrier to engaging in pain self-management. We also see that kids are often not very good reporters on what's happened in their life, and so helping them start to just even self-monitor some of their symptoms is a really important piece of treatment. And we also orient people towards understanding that that our treatment, even though our hope and a positive outcome is a reduction in number of headache days and headache intensity, we're really going to be focusing on function and changing some things before we see a change in pain. And so helping them understand that is actually a very helpful thing to do, that we don't need to be concerned about harming the child in the process or anything like that. So things like returning to school, getting back to playing with friends, just living normal life. Then we go through and help them understand a little bit about pain neuroscience. So the kind of key points here are understanding that pain is an experience that occurs in the brain. It has a protective function, but it's not always the case that it's indicating danger, and that it can sort of go haywire. And we have these different factors where we see that nociceptive signals can either be promoted or inhibited at a few different points. And we think about that in headaches and help kids understand that, once that they have control, I guess, over many of these factors, and that that once pain has become chronic, they're more likely to have difficulties in descending inhibition of pain, of nociceptive signaling. Then cognitive skills training focuses on thoughts, beliefs, and assumptions that people hold, and we really want to identify the maladaptive or unhelpful thoughts that people have. And pain psychology research has uncovered a few that are particularly important, and so we target those when we're thinking about pediatric pain psychology for headaches. So pain catastrophizing is a tendency to magnify and ruminate over the pain experience. And it's one of the most predictive factors of ongoing disability. Fear of pain is the sense that I don't want to do something because I anticipate it'll make my headache worse. And so certainly that's really something that we want to look at. Pain self-efficacy, or the sense that a person has tools to manage their pain or do something when pain comes up. We help people understand or shift from a biomedical model of pain to a biopsychosocial understanding of pain. And so this is that change from thinking about, like, I can take a pill to address this, to understanding that pain is multifactorial and there are lots of things that we can do to address it. Diagnostic uncertainty can be a really important factor to think about. Often we see that patients and families have lingering fear that something has been missed or that something is going on for their child. And when that's the case, it's very hard for them to commit to treatment. It's very hard to move forward. And so helping to understand that, and then often the way we address that is not so much directly trying to alter the belief, but helping them understand and have access to their care team and have a discussion about what the diagnosis is and why the neurologist feels confident in it. And that can be really helpful, and then kind of coming back and promoting readiness for pain self-management. And then pain acceptance. So pain is a normal part of life for everyone. It's going to come up. If you have a chronic headache disorder, there will be periods of time that you likely have pain. And so how can we understand that and work with it rather than fighting it, because that can actually inadvertently heighten pain. And then we want to reduce pain-related disability through cognitive processes like coping ahead, so thinking about situations where you're likely to encounter triggers, planning, problem solving, and goal setting. Behavioral change includes lots of different strategies to just basically change what the person is doing. And so one of the key areas that we focus on is behavioral activation rather than resting in response to headache. So certainly there's a role for rest, but it absolutely should be used judiciously and only when it's helpful for the patient to lay down for a short period of time. Laying in bed all the time is not a helpful strategy, of course, for dealing with headaches. And then we want to increase opportunities for them to be engaging in activities that are fun and help give them a sense of achievement. And we should approach this using good pacing and making sure that children are ready to pair these behavioral changes with coping strategies. We introduce graded physical activity, social reintegration, and return to school. And all of these have an element of exposure, which we know is a key piece of cognitive behavioral therapies. And so by changing the behavior, we often see that certainly we see increases in function, but we also see changes in the beliefs and cognitions that are related to headaches. We teach pain coping strategies like distraction, distress tolerance, self-soothing, all of our relaxation modalities, and then help kids remember how to use the cognitive strategies in their everyday life. And then this lifestyle and prevention piece is really important, as Dr. Pavitt just discussed, but even though these are relatively simple behaviors, they're really hard behaviors to do consistently. So from a health behavior change perspective, helping really to craft a good plan for patients to be successful and for their social environment to really reinforce change in these areas is very important. And in addition to the lifestyle change, the last point on their treatment engagement or adherence. So we know that medications only work if you take them. And so introducing this idea to patients and families, and you'd be surprised at how many people report very poorly on their own level of adherence or engagement. And it's not intentional. We're just not very good reporters overall of our ability to follow through on recommendations. So this graphic here shows the interpersonal fear avoidance model of pain. And it just really is underlining this idea that a child is embedded in a broad social context, and we have to think about all of that and sometimes intervene in some of the components in the social network. So things like parent pain catastrophizing and pain-related fears can lead to parent protective behaviors that result in children no longer functioning as well in the face of pain. So often we meet with parents, and sometimes we need to directly work on their beliefs about headaches. We have to teach skills to change the consequences of headache pain behavior and to reinforce desired alternate behaviors. So meaning if your child is not feeling well, we don't want a lot of extra attention specifically in response to that behavior. We don't want special privileges as a result of headaches. We do want parents to start to really notice when their children are engaging in coping and to praise that and give that attention. We want them to notice when their child is going to school and start to notice and appreciate incremental increases in those desired behaviors. We teach communication skills like support, empathy, how to set expectations and set limits. And we also teach behavioral skills like helping them recognize protective or accommodative behaviors, and then how to actually enforce limits. So these are things that are often part of parent management training within cognitive behavioral therapy, but we often see deficits in the parents that come into clinic, or they're just struggling. We talk about sometimes it can be counterintuitive to parent a child with pain, and some of the things that change when your child is sick or in pain in the short term make a lot of sense or are pretty benign, but then in the chronic context become really harmful. So physiological self-regulation strategies are a key component of CBT for pediatric pain. And so that includes things like breathing, progressive muscle relaxation or passive muscle relaxation, guided imagery, self-hypnosis, and mindfulness. And each of these strategies is aimed at increasing parasympathetic nervous system activity to help counteract some of the processes that can trigger or worsen headaches. It's important to note with patients as well that these strategies have to be practiced regularly. We're trying to actually change the overall resting function, not just respond in an acute context. So we work with children to practice daily. And then biofeedback is a really helpful adjunct and part of the physiological self-regulation. So it involves sensors that provide feedback on a child's physiology. And so they actually can see this mind-body connection and understand that the strategies that they're using are helpful. Let's see. Oops. Go back. Okay. So a couple things to consider in your clinical interactions when we're trying to apply these behavioral principles. We want to think about reinforcers or things that increase behavior and punishers are things that decrease behavior. And so reinforcers really are things like attention, praise, rewards. So if we think about a typical clinical interaction, it's very problem focused. But I would encourage you to think about with these children, spend some time talking about their interests, about their efforts to return to school. Really think about what are the positive things that I can spend time with? How can I praise the parents for making tough but helpful decisions? Consider whether we've accidentally changed the environment in a way that makes it harder for kids to get better. So things like taking a child out of school and signing those notes sometimes can be really detrimental or make it really hard to think about actually increasing function. And then making sure that we follow up. I recommend following up on any behavioral change recommendations, including therapy attendance. So by returning to that topic repeatedly, we're showing patients that we really feel like that's an important change to make. And often people need to hear a message more than once to really move towards a place of making a change. Oops. Okay. So validating the patient's perspective is critical in promoting change. And I mention this because we certainly don't want to over-medicalize or sort of give too much attention to headaches. And so everyone knows that, but it can inadvertently lead to sort of not really acknowledging the patient's perspective. And I think it's very important that they feel heard and that they feel validated. And a lot of chronic pain behaviors actually make a lot of sense when we think about the experience of pain. They're just not very helpful. But showing patients that you understand that they're struggling and that things are hard. And that for parents that it is very distressing to see your child suffer. That's actually a very normative response. And that it often can lead to feelings of helplessness. Okay. And then just a couple last tips. So I recommend emphasizing the headache rather than any psychiatric comorbidities when we think about referring patients. I think that's an easier sell for most people. I can talk about how it helps you better manage stress and that we know pain is a very stressful process. And patients really benefit from hearing that this referral is not because you think that pain is all in their head or that they're making it up. Or it's not an indication that you're abandoning them. That's a common fear that we hear from patients and families. Oh, you're just sending me to the pain psychologist, you've given up. Destigmatize or normalize treatment. And you can share that psychologists are not all focused on clinical abnormalities, that often we're more like a life coach that's helping problem solve changes to things that are bothering patients. Okay, so thank you very much. I'm happy to take any questions.
Thank you so much for that talk. You described a lot of different treatment modalities, and I was wondering if you talk just a little bit about how you choose which ones to utilize on patients, or do you kind of pick one or two or try and utilize multiple ones? What's your approach?
So often I'll look at sort of the comorbidities that might be present and think about what makes sense with that constellation of things that overlap, like what skills will be helpful across different issues that are presenting. And then sometimes it's just based on the psychological conceptualization, and sometimes it's really just guessing, but we follow that up with measures of function and looking at how the patient is doing. And so if, for instance, changing thoughts and behaviors isn't really working for that patient, we might shift over to something like ACT, where it's more about accepting but not reacting to thoughts. So it's just a different sort of approach. Yeah.
Can you please talk a little bit more about nutrition and eating?
Yeah, so those aren't things that we directly intervene with, but we certainly know that that's part of daily life and behavior for patients and families. And so we think about making those changes for regularity purposes. And then I think if there's anything more specific, we're going to be thinking about referring to a nutritionist.
So what about the foods to avoid, like the aged cheeses and aged meats and the ones that have triptans in them, like dark chocolate and things like that? What are you advising patients?
Well, I think Dr. Pavitt could probably answer that question. I will say from a psychological perspective, I often feel like it's not worth the struggle if it's really the parent who's pushing for those changes. Do you have anything to add, Dr. Pavitt?
I was just going to say, I think the way that I approach it is it actually triggers it 100% of the time. And it's a known trigger every time I eat a specific hot dog brand, I get a migraine. Avoid it. Otherwise, we know the triggers are cumulative. And so patients, it can cause a lot of stress to try and track what types of foods I'm eating. And a lot of times it's not actually just that one specific food. And so unless it's something very specific, I say go ahead and eat. It's about timing, making sure your schedule, and having a variety.
And we had a question in the chat. Excellent talk, Dr. Parker. And this might be for both of you. It's what's the wait list like to get into the clinic? And it sounds like y'all are doing such good work.
Can
you get a microphone so that the people in the call can hear you?
Great question. So right now, our wait list to get into the headache program is, I'm looking at my program coordinator who is also here. I think it's about a month and a half. But if we do take urgent referrals, and so if there's any patient that you're concerned about, please don't hesitate to reach out to us, and we can work people in. To get into the interdisciplinary program, that wait list is about a month, 6 weeks right now. We're scheduling out for that program.
Great, thank you.
Thank you all. It is my pleasure to introduce our next speaker. Harry Ong is one of the neuro-ophthalmologists here at UTHA. He is a neuro-ophthalmologist who came via the path of neurology. He did his neurology at Penn and then did his neuro-ophthalmology fellowship at Penn also. He is splitting some of his time to come over and see patients in the Pediatric Pavilion, and today he's going to talk to us about pseudotumor cerebri.
Wow, I was not expecting an introduction. Thank you. It's my pleasure to be here. Thank you for the invite. And I know that basically right now, I'm the only few bodies that's standing between you and the warm weather, so we'll try to speed it up and get it on. So I'm going to give you a brief introduction about this disease entity, pseudotumor cerebri syndrome, which can cause headache as well. Okay, and then the question in my field is often, is there a papilledema or not? Is it this way? Got it. Okay. And I have no relevant financial relationship to disclose. So the objective of this talk is basically three. So one is try to review what is pseudotumor cerebri syndrome, the primary pseudotumor cerebri syndrome, which is often also known as the idiopathic intracranial hypertension. But there's also the secondary pseudotumor cerebri syndromes caused by medications or systemic disease. And also I'll highlight a classic presenting feature of this syndrome, and then also discuss about potential next steps of what to do. So what is pseudotumor cerebri syndrome? The key feature of this syndrome is actually these four things which in order to fit the diagnosis. So one is there should be a presence of papilledema and or sixth nerve palsy, so which is causing the sort of a horizontal double visions. And two, the neuronal imaging should actually reveal normal brain parenchyma, meaning that there should be no brain tumors or any signs of hydrocephalus, like aqueduct stenosis or something that's causing hydrocephalus or increased pressure. And three, it had to be proven by lumbar puncture to have elevated opening pressures. And for adults, it's 25. If the kid is not sedated and not obese, it's also 25, greater than 25. But if they're sedated and they're obese, actually the number goes up to 28. And they're borderline high if they're between 20 to 28. And then the next point is actually normal spinal fluid constituents. So they should have normal chemistry with no signs of sort of inflammation or infection, because that can also cause increased pressure. So then you're going to be treating that instead of sort of treating the high pressure. So like I was alluding to, for pseudotumor cerebri syndrome, there's a primary form, which is what we often also know about, the idiopathic intracranial hypertension. And this is where the association with the weight gain is highly relevant. And there's also the secondary form, which is related to medications, cerebrovenous abnormalities, and medical condition. And I'll talk about more in the case presentations. So the demographic of IIH, I'm just going to delve a little bit more. So before puberty, actually, boys and girls have similar prevalence. So there is no difference in terms of like have more prevalence in girl. And actually, there's not a clear association with obesity. So a young kid coming, a prepubertal boy coming to you for like potential that is possible. But then when after puberty, that's where the sort of what we are commonly are more aware of or taught is basically the pseudotumor highly prevalent in young obese females, which much higher, and a strong association with obesity. And unfortunately, in America, about 22% of children under the age of 18 are now obese or overweight. So that is increasing. But the prevalence of IIH actually, as an overall, is about 1 per 100,000. And then in the female, in a young a post-pubertal, it's about 4 to 20 per 100K. So it's still a very rare disease. So workup of pseudotumor. So if you're suspecting that and it has been sort of found to have papilledema and or sixth nerve palsy, the next thing is getting an MRI brain with and without an MRV, so or MR head venogram. And what we're trying to look for is, like I alluded to, a normal brain parenchyma and no signs of structural lesion causing hydrocephalus. And also, sometimes these sort of MRI can give us sort of radiographic clues about potential raised ICP, such as, actually I don't have a pointer, like the empty cella, so basically where the cellas have the pituitary that kind of push underneath. And then otherwise, you can also have these like tortuous optic nerve, or the optic nerve sheaths are enlarged, or the posterior globes are being flattening. So these are the four sort of common radiographic signs. And then on the venogram, you can also see stenosis of the transverse sinus, not thrombosis. I'm talking about stenosis that they often talk about. But one caveat to these radiographic findings that they could be non-specific. So it doesn't mean that if you have it, the patient automatically have pseudotumor cerebral syndrome. It just sort of points to potentially. And often these radiographic findings actually persist even if the patient may have previously had papilledema or high ICP, they're treated, but these radiographic findings does not reverse. So it actually stay for years. So it could be either a previous papilledema that resolved or just non-specific findings. And afterward, you kind of work with the lumbar puncture to get opening pressure, cell count, and chemistry. All right, so let's go through a case presentation. So if you have a 16-year-old healthy teen presenting with increasing headache to your office, so what do you ask next? So the associated symptom that you often ask is headaches. Like Dr. Pavitt was alluding to, is it worse in the morning or laying down? Is there a positional component? Because if you imagine there's a raised ICP, it would be worse when they're supine rather than sitting up or standing up. And also they have often an associated symptom, which is pulsatile tinnitus. So this is actually a whooshing noise, not a ringing noise. So it's actually a sorry, I'm not doing it very well, but it's just sort of whooshing, like synchronizing with your heartbeat. And there's also a phenomenon called transient visual obscuration, which is a transient sort of blackening of their visions, very quick. It's a few seconds. And then they, especially with the positional change, such as bending over or sitting up, but without other pre-syncopal syndrome. They're not like not lightheaded, it's just a transient vision loss and then comes back again. And then also if you have any horizontal double visions. Out of these, the headaches is the most common but not specific symptom. Pulsatile tinnitus is one of the more specific symptoms, and whereas if you're having daily TVO is actually the most concerning, that potentially means that the optic nerve is swollen and having this transient ischemia, and then sort of causing the TVOs and then relief and then comes back. So the relevant history, so if you're suspecting a pseudotumor, number one question you always ask, especially for postpubertal and females, will be weight gain, weight gain, weight gain. Because as you can see in this sort of prevalence epidemiological studies, that they're now about above 20% of the kids are obese or overweight, and then it's increasing as they age. And then the second question is, are these medications and systemic illnesses that I was talking to that can cause secondary pseudotumor cerebral syndrome? So number one is basically tetracycline derivatives, so like doxycycline, monocycline. Again, the duration in the literature is not very clear, but we're talking about more like months, not like a week course for antibiotics for pneumonia, but it's more like months for usually in the use of like dermatology. Vitamin A or retinoids derivatives often can be used in like cancers for AMLs and also for acne. So even topicals, there are case reports that can cause the pseudotumor cerebral syndrome. And then exogenous growth hormones or high level levothyroxine, lithium, and then corticosteroid withdrawal, and then cyclosporine. And there's actually a case report, the last part, the Mirena IUD, so case reports and also large sort of case control studies that show that there may be association higher, about like twofold in risk of Mirena IUD leading to pseudotumor cerebral syndrome. And lastly, about systemic diseases. So you asked about anemia, Addison disease, which is kind of equivalent to the steroid withdrawal state, renal dysfunction, uremia, hypercapnia, and hypercoagulable states. So what can you do in terms of, from your pediatric perspective, pediatrician's perspective? So first is actually check the blood pressure. In a lot of time, actually, the hypertensive crisis can present as bilateral dysodema and also having headaches. I just have 2 cases in my clinics coming in with undiagnosed hypertensions. So that could be one thing to check first. And of course, check the weight and calculate not BMI, BMI, to see if there's changes in their growth. And that's also, if you can, perform neural exams and if possible, fundus exam. So if in your assessment that the exam for the neuro exam is normal, there's no visual complaints or decreased visual acuity and no other red flags as indicated by Dr. Pavitt, then you can refer to pediatric ophthalmology or neuro-ophthalmology or neurology. The reason I put all there is because there's wait time to get into our thing. So if your suspicion is lower, then you can help triage, because pediatric ophthalmologists or ophthalmologists can often help us diagnose whether papilledema or not, and then can start to initiate initiate workup, like the MRIs as well. But if you really notice that there is an abnormal neuroexam, like a focal neurological deficit, a clear disc edema that you can notice on your fundus exam, or a new onset sixth nerve palsy or horizontal binocular double vision, then they really need emergent imaging, MRI, MRV, because one, you want to make sure there's no tumor, because then that help us. The next step is basically getting a lumbar puncture so we can get the treatment started as soon as possible. And talking about treatment, so there are medical arms and also surgical arms. So in the medical therapies, the first time is Diamox or acetazolamide. And unfortunately, that has a lot of often have a lot of side effect because they taste nasty and they make soda taste nasty. But it is a first line. It works by lowering the CSF pressures. And then there's other second lines such as Lasix or topiramate. And there are, unfortunately, a few cases where there are actually malignant pseudotumor cerebral syndrome where they're actually having a rapid vision loss. And that's where the surgical option comes in to try to alleviate that pressures ASAP. So one is actually optic nerve sheath fenestration or CSF diversion, where we work with the neurosurgeons. And then there's actually a new kit in the sort of the surgical realm is venous sinus stenting, which is actually opening up that transverse sinus and increasing the sort of the CSF outflow. But the drawback is basically once you put that stent in, then the patient has to be on antiplatelet for life. So with that, that concludes my quick introduction about pseudotumor cerebral syndrome, and I will be open up for any questions. Oh, thank you.
So it is my understanding that there is a lot of debate in the world of ophthalmology as to whether or not optic nerve sheath fenestration is something that should or should not be done. I've heard arguments that it's dangerous and risky and causes blindness. I've heard arguments that in the setting of CSF diversion in a fulminant case that it really can be the vision-saving part of that procedure. And I was just curious if you have any insight into why there seems to be such a diverse perspective on that.
Thank you for the question. That's an excellent question. So I guess I was trained in the world where optic nerve sheath fenestration is actually the go-to route, especially if there's a vision loss. But I have seen cases because when you are doing the optic nerve sheath fenestration, sometimes you could have a little bit of pull or tugging on the optic nerve. And there are cases of having like CRAO, like basically artery occlusions, like a major complication that it actually comes out like blind in that eye. So that is a risk that you have to think about. But I was trained basically sort of, if the main complaint from the pseudotumor cerebral syndrome is vision loss, optic nerve sheath fenestration is the first step because that can really reverse the vision or temporize the vision loss. Whereas if you have vision loss with headaches, then VP shunts could be the other route or the long term. Because optic nerve sheath fenestration is a temporizing measure. It's not a long term because after a while the pressure equilibrates and that valve will close. The fenestration will close. So, and long term, you do have to, it just buys you time to either get the Diamox on board to start or get the VP shunt in place. Yes, Dr. Papp.
I'm going to ask you another controversial question. I was wondering if you could just share your insights on IIH without papilledema and your thoughts about all of that.
I knew someone's going to ask that soon. Yes, there is a controversial. So we just had one of our a premier speakers that talked to us, Nancy Newman, came to us and talked about. So IIH without papilledema is an entity, and it's so one thing is basically if you have IIH without papilledema, so they don't have risk for vision loss. So it is a recognized entity, but they don't have vision loss. So the treatment actually plan kind of change. So from what I was taught and learned is basically that now falls more into a collaboration with the neurology. They're treating as if it's a sort of headache syndrome now. So I think you still use Diamox, you can use Topamax, more likely with Topamax, but you don't do sort of serial LP to kind of measure that opening pressure. You just kind of treat it symptomatically, which is very hard sometimes because it's just really hard to manage that. And then the question then is are these patients if they truly does not have papilledema ever and just have IH without papilledema and based on opening pressures and then also the radiographic finding, they're not at increased risk to have papilledema compared to other people. So it's not, yeah, so then it's not, it doesn't mean that they have to be seen sort of ophthalmologist like every 3 months or stuff like that, but they should see ophthalmologist at least every year to make sure there's not developing papilledema. So I don't know if I answered the question, but it is an entity, yeah. Yes.
So how do you distinguish the visual symptoms you're talking about from floaters?
Sure. The question is, how would you distinguish the floater from the visual symptom? Are you referring to the transient visual obscurations? Yeah. So the transient visual obscuration actually is sort of a complete, it's like a transient, actually there's like a sort of closing, blackening of your visions. Whereas floaters doesn't really obscure your vision. You see kind of like a dust kind of floating around. And that kind of move as you move your head and then just kind of persists more in seconds. And then the other question maybe you might relate to, how do you distinguish from a visual aura? Because people can have tunneling vision from migraines and stuff like that. It's more the duration. So TVOs are seconds. So they're very brief with positional change, whereas the aura, visual aura, like tunneling or these like scintillating scotoma, they're minutes, like greater than 5 minutes.
I don't have a microphone, but
I can repeat it.
What's the role of OCT in following these patients, or is there a role for that?
Yeah, that's an excellent question. The question was, what's the role of OCT in following these patients? So with these advances of our technology, we have been following them not only with a visual field, but also OCT, because the question most of the time, if they're swollen, it's pretty easy, then you just treat it. It's basically, when do you take those medication off, or those patients where they're borderline? They have papilledema and also pseudopapilledema, which is out of this talk, but like drusen's, or they just have anomalous optic nerve. So OCT really help us have an in-depth look at the optic nerve and measure them. And the other ideas about OCT that's really helpful is when the optic nerve start to come down, you want to know, is the swelling coming down is because your treatment's working, so then optic nerve swelling, the ICP is lowering, or the nerves are dying. Atrophy, exactly. If you're atrophy, if the nerve is atrophy, the swelling will go down too. So the OCT actually let us look at the ganglion cells, which form the fibers for the optic nerve. So then we can see if the ganglion cell layers are normal, then the swelling is truly improving. That makes sense. So OCT is very helpful.
I'm not going to be able to get them into pediatric ophthalmology anytime, any quicker than anybody else. And so sometimes I send them to the optometrist because they can a lot of times do that. They can even take pictures now. But once you discover that they do have papilloedema, is that like, do they need to go? Like, they're stable. They're not vomiting. They're talking to you. It's just their complaints kind of follow the right story. Is that going to be like you need to go to the ER? Do you need to wait for a month for your clinic? What do you do next?
Yeah, if your suspicion, the question was if you have a high suspicion for a pseudotumor from a pediatrician's office, what do you do next? So I think to expedite it, I think you can first definitely get an MRI for neuroimaging for the subsequent ophthalmologist or pedi-ophthalmologist or neurologist. Because once we have all that MRI that rules out any structural lesion, then we can really proceed with the lumbar puncture. And because I think we're trying to rule out other stuff before we can actually start the Diamox or other treatments. So.
And I also need to know what the proper test is. And so I did see that you did say that if I'm going to order an MRI, in this instance, it sounds like I need to order it with and without contrast and with a venogram.
Correct. Yeah. So yeah, MRI brain with and without, and MR venograms. And that will really help expedite sort of the workup. So like you mentioned, yeah, it's really hard. Unfortunately, it just, there's limited of us. So yeah. Thank you.
Thank you all. That was wonderful. Our next speaker is Elsa Rocho Quinones, who is a pediatric neurosurgeon here in Austin for a few more days. And we're going to miss her sorely. But today she is going to talk to us on Chiari malformation, which fits beautifully into our discussion about pediatric headaches.
Thank you very much. All right, hello everybody. Thank you for standing with us. I know we're a little bit over and it's very cold in this room, so I'll try to keep it quick. I'm gonna see if I can move this properly. There we go. So I have no disclosures regarding this or any topic. Just briefly, I want to give an introduction to Chiari malformations in general. I know there's a lot of confusion sometimes to like which is what. Then take a closer look at the Chiari malformations that we tend to encounter in the community, imaging characteristics, clinical association symptoms, diagnostic imaging that are key, management strategies, surgical approaches, outcomes, et cetera, and then hopefully we have some time for questions. So Chiari malformations, they were first described by Dr. Chiari back in the 1890s. There are 4 main congenital hindbrain anomalies that were described by him. The first 3, Chiari 1 through 3, they basically consist of a type of hindbrain herniation where the herniation occurs sort of as an imprecise continuum between them. The 4th one, which is Chiari 4, was actually confused with a lot of other entities just because it's so rare that throughout the years have been described incorrectly by many, but it actually is characterized by cerebellar hypoplasia and then an occipital encephalocele, so technically herniation of supratentorial contents. Then in the more recent decades, there's been more designations about different types of Chiari malformations, like Chiari 0, 1.5, 3.5, so we won't really go into details of those today, but I'll mention some. I'm going to start with the least common ones and sort of the kind of stranger-looking ones. So Chiari 4 malformation, I already mentioned, characterized by the cerebellar hypoplasia, occipital encephalocele. So let me see if do I have a laser? Kind of doesn't work very well. But the thing sticking out of the intracranial component, that's actually the supratentorial herniation there, occipital, part of the occipital lobe, sometimes part of the ventricle as well. It may involve even midline structures like the superior sagittal sinus. And if you notice in the posterior fossa, the cerebellum is smaller than the posterior fossa there. It is commonly confused with other diagnoses, but we won't get to those today. The Chiari 3 malformation is also one of the rarest and actually, I would say, of the most severe form. And it consists typically of having a high cervical or a low occipital encephalocele that basically goes through that bony defect, if you can see in that sagittal view and coronal view. This one may present with or without spinal cord herniation as well. And as you can imagine, with these structures herniating through defects, the overall mortality rate is quite high. It's 29%. It's oftentimes not compatible with life. The Chiari 2 malformation starts getting into the realm of things that we see more commonly. This one is associated to spina bifida, so it occurs in the setting of myelomeningocele. And it has some very typical features that it's important for us to understand, which includes like caudal displacement of the medulla and the cerebellum. Sometimes it may have inferior displacement of the pons as well through the foramen magnum. In these patients, the foramen magnum is actually quite wide. It's very wide compared to other Chiari patients, and I'll show you a comparison in a second. They also have some typical imaging findings like herniation of the vermis and large massa intermedia. They have elongated fourth ventricles. Sometimes they have callosal dysgenesis and beak tectum, et cetera. Certain of these findings are important for the surgeon, particularly when they're planning on any potential interventions, particularly the low-lying torcula, because they have venous structures that can be quite close to your decompression site. But luckily, in the more recent years, we've started to understand that in these patients, kind of the symptoms that were once thought to be related to the compression of the brainstem, like having a stridor and problems with breathing, et cetera, they're not actually due to the compression, but rather from brainstem dysfunction. So nowadays, you don't see Chiari 2 malformations treated surgically, but rather treating the primary problems like hydrocephalus, et cetera. Now, in Chiari 1 malformations, there's a lot of controversy into what should be the definition of it. Is it more than 3 millimeters of caudal displacement of the cerebral tonsils? Is it 5, et cetera? Well, I would say that anything that greater than 3 to 5, it's been kind of agreed upon Mostly we go by greater than 5 millimeters of tonsillar displacement, but if you see any other associated findings, like a syringomyelia, which is an abnormal fluid accumulation in the spinal cord associated with a greater than 3 millimeter tonsil, then we'll diagnose that as a Chiari malformation. You may have Chiari malformations being congenital versus acquired, so knowing and ruling out a primary reason or etiology, such as hydrocephalus or an intracranial tumor, pseudotumor cerebri, et cetera, is very important, because then when we're focusing on management, we want to treat the primary etiology first. Chiari malformation can be associated with syringomyelia. About 25% of cases may be related. It's certainly higher rates of syringomyelia in some more complex cases, which we'll talk about. In some of the complications that we can see with Chiari-1 malformation, which is, I guess, our simpler form or more common one, are related to skeletal abnormalities and congenital anomalies that can include atlantoaxial instability, platyphagia, basilar invagination, et cetera. And this is just a picture on the left side of typical Chiari malformation. That's just a zoomed-in version where you can see the tonsillar descent across the foramen magnum. Now, for those alternative Chiari designations that I was talking about, the Chiari 1.5 malformation has had a lot of discussions lately. You could think about this as just a complex form of Chiari 1 malformation, where essentially it meets all the criteria of Chiari 1 malformation with regards to the cerebellar herniation. But there's also an additional just appearance of elongated fourth ventricle and also kind of caudal descent of a part of the brainstem or brainstem kinking, which you can see on that picture on the left side. The picture on the right is a different patient who had Chiari 1.5 associated with a syrinx, a syringomyelia, and this patient has already been decompressed. So if my laser worked any better, I could probably point at I cannot. But basically, the posterior fossa, you can see that there's more cerebrospinal fluid in the back of it. Part of the bone from the occipital region has been removed, and there's been a duroplasty, meaning that that dura has been augmented. So it's kind of the primary way of treating something where we see already there's compression and an associating syringomyelia, which I'll go over a little bit more later. Now, the Chiari 0 malformation has also been more of a kind of recent description and is very interesting and controversial because in this form, there is no tonsillar descent. There is technically no obvious craniocervical compression syndrome, but there is actually syringomyelia that is thought to be related to kind of arachnoid adhesions and just basically obstruction of the obex and CSF flow. The way that these patients have been diagnosed with a Chiari 0 malformations because they've already undergone treatment for posterior fossa decompression and had improvements in their symptoms and or syrinx with reduction of the size of the syrinx. Now, going back to the Chiari type 1 malformation, which is the more common than what we're going to find, their symptoms are associated to kind of three major things. CSF obstruction at the craniocervical junction, which will give you that typical Valsalva-induced occipital or upper cervical headache, and symptoms that are similar to hydrocephalus symptoms, like any intracranial pressure symptoms, nausea, vomiting sometimes. They may not be the typical headaches or typical symptoms, but they can be, they have been reported. So patients that present with these symptoms, I do often consider even visual evaluations to make sure that they don't have papilledema, because even though it's not a majority of them, about 15% of them have been reported to have papilledema associated with it when it's been severe. Now, symptoms associated to cerebellar brainstem or cranial nerve dysfunction have also been reported, and of course, these are the ones that trigger our questions of making sure, like, well, are you having any swallowing difficulties, coughing, choking, aspiration, difficulty with snoring at nighttime? Any question of central sleep apnea or obstructive sleep apnea should be looked into with these patients. And I would say less common, but also reported have been those autonomic symptoms related to POTS, et cetera, syncope, drop attacks, sinus bradycardia, and tachycardia with postural changes. That's definitely a lot more controversial, but it has been seen particularly in patients with connective tissue disorders. And the final spinal cord dysfunction symptoms, mostly related to the syringomyelia, you can see scoliosis, which more commonly will have thoracic levoscoliosis, so the curve to the left side. So you definitely see that in one of your patients, and the younger they are, it's a very red flag, and you do want to look into it, get scoliosis films, and do the full evaluation. And then you can see upper, lower motor neuroscience, motor weakness, spasticity, sensory changes as well. But by far, everybody, and especially surgeons, will focus on, well, what about the classic Chiari headache? Do you have the classic symptoms that could potentially put you in a category of patients that is more likely to benefit from an intervention from decompressing your posterior fossa? So those are the occipital or upper cervical headaches that are Valsalva-induced, like coughing, choking, sneezing, laughing. If you're straining in the bathroom, is your kid coming after that, like crying and telling you that my head hurts because I was trying to go potty? So that's one of the things that will tip you off. And these headaches tend to be of short duration, so that's one key as well. So associated comorbidities are very important with these patients because it definitely changes kind of the severity of their presentation and also just the complexity of their Chiari and the potential need for surgery. So these anomalies that have been here are just a handful of the ones that have been recognized. And skeletal anomalies, multiple congenital anomalies, undiagnosed craniosynostosis symptoms or syndromes, those are very important to rule out. Like I said, also connective tissue disorders have been linked to this because there's been an association with actual hypermobility and lentoaxial instability and cervical instability leading to these problems as well. As a matter of fact, the things that have been, or I guess like the different aspects of their management and their presentation that have been looked into, age diagnosis is one of them. So for patients who had multiple congenital anomalies or skeletal anomalies, actually the age of diagnosis has been lower, and it's thought to be because it's more severe. The tonsillar descent in these Chiari patients is also higher, meaning that it actually descends a lot lower for these patients with multiple congenital anomalies. Similar situation for the obex position. And the rates of hydromyelia have been higher in patients with both skeletal comorbidities and multiple congenital anomalies, particularly the ones in this list. And of course, as you can imagine, then the rates of posterior fossa decompression surgery have been higher for those same patients. And as you can imagine, then incidental Chiari-1 malformations, or the bread and butter, basically the ones that we encounter the most, are typically non-syndromic patients. So we get asked a lot of what should we get or what should we order for imaging. And I would say that tonsillar descent is very commonly found in incidental imaging, now with the ease of getting a CT on everybody, particularly post-trauma. But it's definitely not the imaging mode of choice. So MRI is still the modality of choice. And in a patient with a very high suspicion, like Dr. Ong said, or a confirmed Chiari malformation, you definitely want to get brain and spine imaging. It's recommended because you want to rule out hydrocephalus, supratentorial lesions, and also want to evaluate for serrings and other coincidental spinal anomalies that will help us kind of risk stratify these patients into their management subsequently. Cine MRI is a modality that has been helpful for some. It's controversial as well. It actually helps to assess the CSF flow and the dynamics of the tonsils around the foramen magnum. Where essentially we look at, is the flow looking normal or not? Sometimes it's really non-diagnostic and you just don't know. And you have to go with your initial kind of gut instinct. But there have been some studies, including one by our very late Dr. George, who they looked at the correlation of these patients with abnormal CSF flow on cine MRI, and they actually had a positive correlation of post-op symptomatic improvement as well as improvement of their CSF flow after decompression. So some people still use it as part of their management strategies to kind of stratify these patients. Now, if we have patients with known bony abnormalities, such as basilar invagination, the Klippel-Feil, like cervical fusions, atlanto-occipital simulation, it's important to get cervical dynamic films, essentially like cervical flexion extension films, to make sure that they don't have cervical instability, because these patients may actually need to be managed in a different way with regards to their posterior fossa decompression and potential stabilization. So these strategies I keep talking about, you can imagine that there's significant variation. You ask a group of 10 surgeons and you're going to get 10 different answers of how to do this. But I think that there's some generally agreed upon principles. Primarily, if this is an acquired Chiari with a clearly identifiable etiology, you want to treat that first. Right? If months later you have symptoms that persist and they're referable to the Chiari, then you may consider surgical decompression, but all in the knowing that If symptoms are not classic, you may not necessarily have an improvement in certain symptoms. Now, asymptomatic or non-classic symptoms, no syrinx, you can consider conservative management and follow up clinically and also with imaging. Asymptomatic or non-classic symptoms with a syrinx, if the syrinx is mild, you can consider conservative management and very close follow-up with imaging reevaluation. If there's any worsening of the syrinx or worsening or new development of symptoms, and consider surgical decompression. And with symptomatic patients, if you have the classic Chiari headache, no syrinx, but very debilitating symptoms, consider surgery. Classic Chiari headache with a syrinx, we usually recommend surgical decompression. And if you have any of the cranial nerve dysfunction, brainstem compression, or spinal cord dysfunction symptoms that seem to be referable to the Chiari, then certainly surgical decompression would be recommended. For the surgical strategies, it also varies a lot, but in general, I think the bulk fall under just suboccipital decompression with potentially bone-only decompression versus dural splitting, dural augmentation, meaning that we do a dural patch to turn that area from having like a medium-sized shirt to an extra large-sized shirt, okay, and give more space to that. Here, there's just an example of dural splitting where essentially you can compare that to just moving the button down on your belt and giving a little bit more space. Versus just doing the kind of the full works and opening the dura and exploring to see if there's any arachnoid adhesions like the ones that you see on this fourth ventricle right there on the left side in the lower image, where there's like sort of like a membrane that's forming a bubble, and then opening that to allow CSF to flow freely. When these strategies have failed, and patients needing reduced surgeries oftentimes, then not often, it's not very common, but they may undergo placement of fourth ventricular stents. And with the minority of patients, like the ones I mentioned with potential cervical instability or skeletal abnormalities, in the more recent years, groups have actually looked into ventral decompressions with occipital cervical fusions, but that I would say is definitely a minority. So what we know so far is the classic Chiari headache symptoms tend to improve after decompression. The syrinx resolution or significant reduction can be seen in 80 to 85% of the patients after that initial decompression. But syrinx recurrence definitely may occur still years to decades after improvement, just kind of highlighting the importance of having a long-term follow-up for these patients and taking their symptoms seriously if their headaches recur. It's not something that we want to dismiss thinking like, well, you've already been decompressed, you should be good. So scoliosis, when it presents with syringomyelia in these patients, if it's less than 40 degrees, it will commonly stabilize or improve, particularly in patients that have not reached their bone maturity or less than 10 years of age. And like I said, a minority of patients with significant ventral compression and showing up with medullary dysfunction that also have potential lentoaxial instability, dynamic films will be helpful. Sometimes even doing preoperative assessments with cervical traction if they have improvement, then may determine the need for an occipital cervical fusion. So some closing remarks. Chiari-1 malformation, definitely often diagnosed incidentally. Most cases will be non-syndromic and simple, but some can be very, very complex. That presence of comorbidities will be very important. It impacts the rates of syringomyelia development and also the need for surgery, so it's important to look into that. And although most of them are non-syndromic, you want to be very thorough in your clinical evaluation and looking for growth parameters, meaning head circumference, and are they too short? Do they have any hormonal deficiencies or any vitamin deficiencies can be related to that. Scoliosis examinations and evaluations for joint hypermobility, which can be quite simple and done with the Bainton's test. Especially because they can have differing rates of syringomyelia and the need for surgery. And then finally, just posterior fossa decompression. It appears to be effective for properly selected patients, definitely not without risk, but something that if you have any questions about patients that may need to have a referral, just definitely reach out to your neurosurgery group because we don't want to have these patients get lost through the cracks. Okay. And some references that I've selected from here. I'm happy to take any questions if there's any questions.
Thank you very much for the talk. Just curious, for those patients with asymptomatic, how often do you do the imaging follow-up? Is it 6 months, a year? And then for those like asymptomatic but with syrinx, how often do you also do the imaging?
That's a great question. So for asymptomatic patients, and this will vary a lot depending on preference of the surgeon, but if there's no serings associated in the initial imaging, I will just wait for a year typically, and or sooner if there's any symptoms that change, et cetera. If there's a serings present, I tend to prefer the shorter course, like just maybe re-imaging in like about 6 months to make sure that the serings is not increasing in size. That's a great question too. So it actually it depends on the age for the patient as well, because we know that the degree of tonsillar descent and the evidence of cerebral hydromyelia, it actually changes with age. Sometimes you see improvement in it just based on just anatomical evaluations that have been done with different age populations. So it's kind of dictated by their symptoms. How symptomatic are they? How reliable are they with reporting symptoms where we may or may not hear from them, or they may not catch the symptoms, and really you just want to be able to do that neurological evaluation yourself and know that nothing's changing, plus also getting the kind of the objective imaging evaluation. So when they're really young, sometimes I do watch them until at least like they get to preteen, teen, and teenage when they're able to like really tell us what's happening. And we may have just multiple ways of looking at their symptoms, right? Like depending on the level of suspicion, I may have them not only just follow up with us, but if we're treating conservatively, then we don't want to have them suffer with their symptoms, even if they're not classic. We want to refer them to Dr. Pavitt for headache management, or we want to make sure that they're seeing you to rule out like the development of papilledema, et cetera. So we'll make sure that they have sort of follow-up and a close clinical monitoring in one way or another, particularly if we feel like some of the symptoms may be missed by the families, although they often are not. Families tend to over-report, if anything, but you still want to make sure that you have that coverage.
Two quick questions. One to follow from Harry's. Should we be referring, anyone who has any symptomatic sort of incidental finding, even if it's, 5 millimeters below the Freitman magnum?
That's a great question. I would say yes. If there are significant questions about any potential symptoms that may overlapping, that you're not quite certain if they're referable to that, if the patient seems to have any other comorbidities, parental anxiety, et cetera. In reality, it's a conversation that we can have, because we can determine also how close do we need to monitor these patients, or do we follow them as needed, right? And that education, that initial education with the family is very key, because we can talk to them about the natural history of the Chiari malformations, right? What things to look for, what are the potential management, things that are going to tip off our management one way or another, so that they're very understanding of that. And getting a sense of truly how well they understand, how they grasp it, then it helps us to know, how close do I need to keep this kid on their supervision by neurosurgery, and do we trust to just let them be on follow-up with as needed patient or not, or as needed basis or not. So I would say you're not going to go wrong with referring a patient to neurosurgery for that. There's going to be a very simple initial evaluation where we don't need any more follow-up with you, and especially if they have absolutely no symptoms, versus we should keep this in check, or maybe we need more imaging to look at this other association, et cetera. So, but great question. Thank you. All right. Thank you very much, everybody.